Very good evening, everyone. On behalf of Translumina, I, Richa Sharma, welcome all of you to BIC 2021. Thank you very much for joining us for the session on Hotlines and Innovation in Treating Left Main. So we have Dr. Nikhil Kumar as our moderator for this session. Though he doesn't need any introduction, still I would like to take this opportunity to introduce him. Dr. Nikhil is highly skilled interventional cardiologist and he is extremely proficient in new devices and technologies as well. Currently, he is associated with Fortis Hospital, Gurgaon as a Director Intervention Cardiology. So I formally welcome all of you once again. Over to you, Dr. Nikhil now.
Yeah, thank you, Richa. And good evening, everybody. So I'll take a minute to just go through with a brief introductions of the chairpersons. Dr. Balbir hasn't joined us yet, so he is the chairman cardiac sciences at the Max PanMax hospitals, presently with the Max Devki Devi Heart Vascular Institute Saket. He has contributed a lot towards development of new technologies in the field of invasive cardiology and has created new vistas in the managing of complex lesions. He has been awarded the bestowed upon the Padma Shri for his meritorious services. We have Dr. Jagdish Parikh. He is the director cath lab at the SR Mehta Hospital, Mumbai. He is a great academician and a proficient intervention cardiologist. Has a great academic track record and shows us the way, leads the way in doing a lot of complex PCIs. We have Dr. Prakash Chandwani. He's the director and the chief intervention cardiologist at the Heart General Hospital, CKS Hospital, Jaipur. He's, a very, very accomplished intervention cardiologist. And he is one of the few cardiologists to earn all the international affiliations in one single year. That's very creditable. The panelists, we have Dr. B.B. Chanana. He's a senior intervention cardiologist and the head of Department of Cardiology at the Maharaja Agrasen Hospital. They're all very accomplished interventionists. This is Dr. Jaspal Arneja, senior intervention cardiologist at the Arneja Heart Multi-Speciality Hospital, Nagpur. We have Dr. Kamal Sharma, who's an interventional cardiologist and associate professor in cardiology at the Apollo Hospital International, Ahmedabad. Dr. Kartik Vasudevan, he's a senior consultant in interventional cardiology at the Columbia Shah Hospital, Bengaluru. Dr. Pramod Kumar is the intervention cardiologist of repute at the Fortis Hospital, Shalimar Bagh, Delhi. Dr. Shuvanan Ray is the senior intervention cardiologist at the Fortis Hospital, Anandapur, Kolkata. He's a very renowned interventional cardiologist from East India. Dr. Uday Khanolkar is an intervention cardiologist of repute, presently with the Narayana Institute of Cardiac Sciences, Bangalore or Bengaluru. Dr. V. Rajshekhar, senior intervention cardiologist at Yashoda Hospital, Hyderabad. And we have a very, very, appetizing, inviting feast of presentations. And I'll take you through one by one as we start. So I presume Dr. Shravan, intervention cardiologist at the Paris Hospital, Patna, is the first presenter. So may I invite him to take us through his presentation.
So should I start presenting the case? Sir, should I start presenting the case?
Yes, sure, please. We're waiting for you.
Yes. So, very good evening, everybody. Respected chairpersons, moderator, panelists. Today, I am going to present an interesting case of calcified left main bifurcation lesion, where we have done angioplasty using IVL under IVL's guidance. This case was done in Sunshine Hospital by our team of cardiologists headed by Dr. Sridhar Kasturi. Coming to the clinical history, we have a 52-year-old male patient who is a diabetic, hypertensive, and he was recently diagnosed to have chronic kidney disease. He was started on a hemodialysis in a peripheral center. And during the hemodialysis, he developed acute coronary syndrome, inferior wall MI, during the dialysis. His 2D echo showed RWM in the inferior wall with moderate LV dysfunction. He underwent angiogram out in a peripheral center which showed triple vessel disease, and he was referred to our center for further management. Investigation wise, his hemoglobin was 9.6 and his serum creatinine was 4.95. His drop I was 1.7. So on presentation to the casualty, he was in heart failure and was requiring NIV support with a high creatinine. So this is the coronary angiogram which was done in the peripheral center. So it is a left dominant circulation. The RCA is a non-dominant vessel which has mid-total occlusion, and you can see a distal left main bifurcation lesion which is a calcified. Both the LAD and LCX, you can see they are heavily calcified, and there is a large chunk of calcium in the proximal LCX. So this is a caudal view. Here also you can see the distal left main bifurcation, and the proximal LAD and the proximal LCX are having tight lesions. So after the angiogram, this patient was requiring NIV support and he was requiring regular dialysis. But we have admitted this patient in our ICU. We have given a hemodialysis overnight, and we have discussed about the pros and cons about CABG and multivessel PCA. So this patient was requiring hemodialysis. Is a case of CKD, and the attenders were billing for multivessel PCA. So we have taken up this patient for multivessel PCA. So both the vessels, both the LAD and LCX were heavily calcified. So this patient definitely requires plaque modification. So we were thinking whether to use ROTA or IVL. This patient was requiring NIV and heart failure. We thought if we use ROTA, slow flow, no flow, if the patient develops slow flow, no flow during the ROTA, it may not tolerate the situation. So we have proceeded with the IVL. So during the procedure, we have engaged the left main with the 7 French EBU guiding catheter, and the LAD was crossed with run-through wire and LCX crossed with BMW wire. And in the second image here, you can see even the IVUS catheter was not crossing the proximal LCX. So it was having a tight lesion in the proximal LCX. Even the IVUS catheter was not able to cross it. You can see the guide catheter which is backing out. So we have pre-dilated the lesion initially LCX and LAD. LCX we have pre-dilated with 2.5 into 12 mm NC-TREC. And later LAD also we have pre-dilated with 3 into 12 mm NC-TREC. These are the post pre-dilatation images. After that, we have done the IVUS for the patient. Here you can see the LCX. It's almost 180 to 270 degrees arc of calcium. Here you can see. And as you go nearby, you can see almost the ostial LCX. This is the OM branch. Here you can see the ostial LCX, which is Here you can see the ostial LCX, which is very narrow. And even this is the distal left main, which is having some calcium. This is the LAD. In the second image, you can see the LAD almost 360 degrees arc of calcium. You can see in the LAD. This is the IVUS interpretation. You can see the LCX almost 180 to 270 degrees of calcium, and the LAD almost 360 degrees arc of calcium. You can see, and even the distal left main was having around 90 to 180 degrees of calcium. So this patient definitely requires plaque modification. So we went ahead and we used IVL. We have used 3 into 12 mm balloon. We gave 3 cycles, 30 pulses to the LAD, and we gave 5 cycles, 50 pulses of shock waves to LCX. Following that, we have done the IVUS. The vessel was slightly open, and there were some cracks in the calcium. In both the LAD, the LCX is on the left side and the LAD is on the right side. Then we have pre-dilated both the LCX and LAD by using, again we have pre-dilated using 2.5 into 12 mm NC-TREC in LCX and 3 into 12 mm NC-TREC in the LAD. Then LCX stenting, we went ahead using a TK cross technique here. The LCX stenting was done by with the 3.5 into 18 mm Resolute Onyx. Then we have removed the stent. We placed the 3 into 12 mm NC-TREC in the LAD. Before implanting the stent, we removed the LCX stent balloon and the guide wire, and we crushed the LCX stent by using 3 into 12 mm NC-TREC balloon. Following that, we recrossed the LCX wire through the stent struts, and we have opened the struts using 2 into 10 mm Tazuna balloon. Then we performed first kissing balloon dilatation by using 3 into 12 mm NC-TREC in LAD and 3.5 into 12 mm NC-TREC in the LCX. Later, we implanted LMCA to LAD stent we have used 3.5 into 38 mm resolute onyx stent. Later, we performed part of the left main by using 4.5 into 8 mm NC thread. The right side image is following part. Then later we recrossed the wire to the LCX and the studs are opened with 2 into 10 mm Tazuna. Then second kissing balloon dilatation was done by using 3.5 into 12 mm NC in both LED and LCX. Then we post dilated, like dot was done digital optimization of LED with 3.5 into 12 mm NC thread. And this was post tenting IVAS images of both LED and both LCX and LED. Like we were satisfied with the result, almost 3 mm diameter in both LED and LCX. Like we thought the ostium, the vessel, like it's nicely opened. The ostium of the LCX, we thought it was not properly opened here. The ostium was still having some disease. This is interpretation. The ostium LCX, we thought it was still narrow. So we have done a third dilatation, like a third kissing balloon inflation here by using same 3.5 into 12 mm NC in both LED and LCX, and we went up to 18 atmosphere. And this is the final result. After we have done the report by using the 4.5 into 8 mm NC. And this is the final result. Nice TIMI3 flow. And there were no complications. Then we shifted the patient back to ICU, like he required hemodialysis post procedure. Following that, his heart failure improved and he was doing well. Coming to the mechanism of IVL, I just wanted to say a couple of slides. Like as you know, it is the IVL catheter is passed over a standard guide wire. The balloons, there are 4 sizes: 2.5, 3, 3.5, and 4. The IVL balloon is sized 1:1 to the reference artery. Initially, it is inflated to 4 atmosphere, and then we give the pulses. Like in each cycle consists of 10 pulses, and then after the pulses, we further dilate to 6 atmosphere, and then we deflate the balloon. So the mechanism is the electrical discharge from the emitters vaporize the fluid within the balloon, and it creates a rapidly expanding and collapsing bubble, which generates the sonic pressure waves. And these pressure waves, they create a localized effect. They traverse through the soft tissues, and they selectively crack the calcium. Like the IVL advantages, it has a low complication rate compared to rota, less chances of slow flow, no flow, as there is no debris production, and there are less chances of coronary dissection or perforation. And it selectively interacts, like even for a medial or inner adventitial calcium also can be, for IVL can be used, where rota cannot be used. Like unlike atherectomy, IVL can be used with more than one guide wire, protect the side branch. With rota, you cannot use the guide wire in the side branch, as it can break the side branch guide wire. And like the proposed mechanism, like it can be used with kissing balloon technique also, because of the presumed ability of IVL to propagate across the second balloon. So you can use one balloon as a IVL balloon, and the second balloon is a normal NC, and you can view the pulses. So it can view to the main branch, and the side branch sonic waves can be passed to the main branch and the side branch. So like IVL, like if there is an underexpanded stent with underlying calcium, you have only 2 options. Like either you can use an IVL or a high pressure balloon like an OPN NC. IVL has shorter learning curve. It is just like a normal balloon. Compared to rota, it has a shorter learning curve. And even in large diameter vessels, like up to 4 mm, you can use this IVL. In some conditions, rota is preferred over IVL, like severely calcified balloon uncrossable lesions. As you know, IVL balloon is it is a thick balloon. So in balloon uncrossable lesions, we have only option to go ahead with rota ablation. And a long segment calcified lesions, like if it is a long segment lesion, you have to use multiple IVL balloons, so the cost will be more. So better to go ahead with rota. So in conclusion, in patients with severe coronary calcification, IVL is safe and effective with minimal complications compared to other techniques like cutting balloon, high pressure balloons, or other devices. I thank one and all for giving me this opportunity.
Thank you, Dr. Shravan. I think this is a very, very nicely done case, and perfect timing on your, thank you for sticking to the time. The case is open for discussion. May I invite the panelists. I wish to apologize to Dr. Shuvanan Ray. I wrongly introduced him as a senior interventional cardiologist. He's the head and director cath lab, and the senior cardiologist, a very renowned cardiologist from Calcutta. He is presently with the Fortis Hospital there.
May I ask one question?
Yes, sir.
Shravan, I have
Yes,
one query and one suggestion. When we see such heavily calcified lesions, we never put IVAS catheter straight away, because IVAS is okay, it is little safe catheter, but OCT, Once you put and it is damaged, you will have a big loss financial of 80,000-90,000 to 1 lakh. So what we do when we see such heavily calcified lesion, we do test run with 2 millimeter balloon. If 2 millimeter balloon goes through, then only I go ahead with either IVUS or OCT. Otherwise, I pre-dilate so as to save the cost of the OCT. Now, the second is the question. You said you did 3 IVL 30 runs on the LED and 5 runs on the SIR, right?
Yes, sir. Yes.
Now, tell me how you decide that what you have done on LED is adequate and now you should stop and go to the SIR because you have only 80 runs. So how do you decide? You do IVUS again, you did trial with NC balloon, or you assume?
So like after the IVL, we have used like 3 to 10 mm NC balloon in the LED, and we have pre-dilated again, and the balloon was opening fine. And later we have even confirmed by doing like IVUS.
So this is a big problem when you use IVL balloon for 2 different vessels. If it is in the same vessel you are doing lesions, it is fine. You just have to move the balloon up and down. But when you pull it out from one vessel, assuming that you have done correct and you go to the second vessel, and if you exhaust all your 80 pulses, you are left high and dry. So we still do not have perfect method to know what we have done is adequate. Has anybody else any comment on this?
I think it's a very valid point you brought out because there's no way to decide whether you're
correct. So because we can't afford second balloon.
Probably he did it because there was more calcium in the circumflex than in the thing. So.
No. In fact, he needed 50 runs of IVL.
Yeah, possibly. One would like to use 2 catheters here. So that disadvantage is not there with rotablation. Because there you can use.
No, see, rota would have been unsafe. We don't know what was the ejection fraction. He never mentioned.
So
his point is well taken.
Can I make a point here, sir? Can I make a point
with rota, he would have more trouble.
Can I make a point here, sir? Parikh, sir.
Yes, please, sir.
Please go ahead.
So point is also, the ostium of the circumflex is at an angle. So
90 degrees.
If it is an angulated lesion, IVL balloon cannot be put in an angulated lesion nicely. So that is the reason why it did not yield after the IVL 50 shocks, perhaps. So in that case, I think I would have gone for, after IVL, I would have gone for a very high pressure balloon. So open the ostium of the circumflex.
So when you are very right, after IVL, either you do Wolverine or you do OPN balloon for especially ostial SIR because they are nasty lesions.
Yes.
Jagdish, Uday Khanolkar.
Yes. Hi, Uday, bol.
Acha, before going to circumflex, after
Yes.
doing the IVL, and of course he has done used a NC balloon also. I would rather do a IVUS, confirm what we have done, have we done a good job to the LED or not, and then go to the circumflex and then use the IVL balloon over there. I would follow that path.
But Uday, the problem is the Disrupt Trial 3 says that even if you don't see cracks, it is cracked. 30% of time they did not see the cracks and still it was cracked. So we don't have very objective criteria to say that we have done correct job with IVL. So if you are going to use one IVL balloon for 2 vessels, this is a dilemma that I face. That when to say.
No, that's
we
fine.
use like the complete 80 pulses in the patient, sir.
Pardon me?
I think like we use the complete 80 pulses, like we
But
give
then
30 and 50 pulses to the
balloon,
we thought like.
The problem is the cost is so prohibitive that we can't afford second balloon.
Yeah,
Yes.
can I make a comment? Dr. Kartik here. I think when you see the waist giving way, when you inflate the balloon and when you give the pulses, the waist gives way. That is one of the indicators that it is adequately cracked. I think that's a very important sign you have to look for. And also the trials have shown, though if you do an OCT and don't see cracks very well, there are micro cracks which
yes, 30% of time.
Yeah, quite adequate. So one way of looking at it is the waist giving way. But having said that, I've done a couple of cases where the waist doesn't give way at all, and I've exhausted all the 80 pulses. But that was a single vessel. But as you said, if it's a 2 vessel, when you're going to stop is a big question. The one important thing is if the waist gives way, then you can go ahead with the stop there and go to the other vessel.
But your pressure inflation with the IVL balloon is with the low pressure. So I mean, I don't know whether the waist giving way is a very reliable way to decide. The point taken is that I think it's still very arbitrary, and I think till the cost comes down, we would be resorting to decisions like this, and then keeping our fingers crossed. I think last one final comment from Dr. Uday.
Yeah, even once the waist gives away and you have used a NC balloon over there adequately, again the NC balloon diameter waist is almost disappeared, and you do an IVUS, you are now interested in achieving a satisfactory area at the critical part. You may not completely take care of the calcium, but having achieved, you are comfortable enough to deploy a stent now. That is the point. You can stop and use it for the circumflex. That is what I meant by I was using before taking a final decision to switch the balloon to the opposite, to the another vessel.
So you mean basically an IVL followed by a pre-dilatation with an NC balloon, see the waist going, and then you come back and do the other one?
No, before you go to the circumflex, you do a proper IVUS or a OCT or whatever it is.
Sure, point taken, I think. So I think we'll move on to the next presentation by Dr. Shuvanan Ray on the guide catheter story.
So,
no, is it? That's what I was told.
Am I visible, sir?
You're visible, sir.
Yeah. So, firstly, I want to express my gratitude to Translumina for giving me an opportunity to talk about guide catheter in complex PCI, which is an underrated device, and it's not moving. Why it's not moving? The most underrated asset to coronary angioplasty that prevented the launch of PTCA on March 22nd, 1976, and after that, when they understood the importance of guide catheter, it took 3 years, at least 3 years to launch the PTCA. So guide catheter, we know that there are certain functions of guide catheter. It helps in injecting contrast. It is a tunnel through which we put the devices in, and it also gives the backup support. So 3 things are important: size, support, and shape and curve. So depending on that, different guide catheters are there. And also, when you put a guide catheter, we need to see that whether there is any dampening of the pressure. Therefore, everybody of us, we know, but we do not memorize, or we do not, we take them casually sometimes, do not see that whether the guide catheter is dampening pressure, or whether there is a significant lesion in the ostium, or it is non-coaxial. So, and also sometimes there is an excessive tortuosity in the iliacs, and when you put the guide catheter in and the guide catheter gets twisted, and then it creates a problem and you cannot put devices in. So I would show you 2 cases. Number 1, this is a case, clinical case, aged 78 years, who is having CKD on hemodialysis, came with inferior MI, and PAMI2 LCX was done, and in October 2020. This is the right side, and this is the left side, and they have done a good PAMI in the circumflex and putting a long stent, and also there is some lesions in the left main, which was not done anything during the time of PAMI. But from January, the patient was having severe chest pain, particularly during hemodialysis, and ECG changes in the anterior valve started to come. And angiography and revascularization was planned. But unfortunately, his right radial, which was used for the PAMI, was obliterated. The left radial artery had a fistula. Both femoral pulses are weak. The left is almost imperceptible. The right is there. And So we started from the right femoral root, and it is the right femoral after the sheath. But after the sheath, no guide wire and no, sheath guide catheter was moving in, and you can see that the aorta is thoroughly calcified and crooked. And also we gave a shot, and then we showed that there is a 90% lesion at the ostium of the common iliac artery on the right side. So we planned for a balloon dilatation of the ostium of the right common artery with a Mustang 5 millimeter balloon at a very high pressure, 20 atmosphere, and so the calcium yielded. And then we put a 4 millimeter balloon, and as a balloon tracking method, like radial, we put the balloon in, and on top of that we put the guide catheter and entered the coronary artery, left coronary artery. And it was seen that in the left coronary artery, the LAD ostium is narrowed, and also probably the left circumflex stent has entered inside the left main artery to some extent. So we did an IVAS, and it was seen that the LCX stent has compromised and initiated plaque rupture perhaps in LAD, and LCX stent is eccentric. One part enters the LMC and other part misses the ostium. There is an LMCA disease with pre-IVAS area is 2.3 millimeter square, and also there is an LAD osteal disease. So we planned nanocrush. This is our technique. This is a bench test, and we put a one size smaller balloon in the main branch, and put the side branch stent, and pull the side branch stent to the main balloon, inflated balloon, and then we inflate the stent, and then we pull the stent balloon towards the main branch and dilate the ostium of the side branch. And then we do the fast kissing, and along with kissing, we before that we crush the side branch stent with the main branch, and then do the fast kiss. And after that, we took a micro CT to see that the side branch stent ostium is flared, and it is not crushed. Actually, it is flared, and it is just like a flower petal like appearance. Then we put the main branch stent, and we did the power pot. Then we crossed into the side branch, then did the first second kiss, and we ultimately we finish with the report. And this is the micro CT image after the proper procedure. So with that, we put the two wires in the two vessels, and we dilated with scoring balloon on the LAD ostium. And then we did again, we actually, like the bench model, we just put the stent in the LAD as a side branch, and put the balloon in the circumflex. And this is the first case. Then we put the stent in the, it is a giant stent in the circumflex, and which is taken as a main branch from the LMCA. Then we did a pot, then we did the final case, again report, and this is the final result. So the patient is doing well, and this is the final result. There is some lesion in the LAD, and we did also an IVAS, which showed good areas. LMC area is around 14, LAD ostium is around 10. So this is a case. The importance of this case conclusion is our nanocrush technique is an effective solution to all angles of bifurcation, including narrow angles. And CBCT images demonstrate excellent reconstruction of the bifurcation segment after stenting without excessive metal load around the SB ostia. And also the importance of balloon tracking, particularly even in the femoral artery, where there is extremely calcified and crooked aorta. You can use a balloon tracking method so that the guide catheter is not twisted. So that again, there are some safety measures which applied rigorously when manipulating guides, to aspirate the guide vigorously and to insert general black bleed. We know that, but also importance in our country, usually the aorta is narrow, and GL3, GR3 are the diagnostic cuts So we do not have extra backup catheter, XB 2.5 and EBU 2.5. And that's why sometimes it becomes bigger even in the normal size aorta in our country. So this is a patient who was planned for angioplasty, who is FFR positive. And you see the patient was tried from the right radial root. This is an EBU 3 and there is a non coaxial alignment of the guide. When the wire was put and the balloon was entered, suddenly the operator noticed that there is a Jaspal lesion in the left main and there is a left main dissection. So what next? Next we took a GR catheter and we put the femoral root on and put a GR catheter. And it is a larger catheter. This is a 7F catheter, and we put 2 wires in the LAD and in the circumflex. And then we dilated with a balloon and we put a stent in the distal part of the LAD. And then we put a stent in the proximal part, overlapping the first stent. And when we remove the balloon, suddenly there is a huge perforation. And we never understood that the LAD wire has gone through the flaps into the subintimal space and then entered the main lumen, and there is a huge perforation. So with the perforation, you can see the perforation, and we put the patient went into tamponade and cardiac massage was given, and then we put a pericardial pigtail catheter drain, and then we put a papyrus cover stent from the ostium of the LAD to the proximal LAD and inflated in the high pressure. We post-dilated the stents, and we did also a pot. We have not seen this. After the papyrus stent, the flow was, the perforation was sealed, the flow established in both the vessels, and this is the final result. So in conclusion, the guide cath selection is the most important step of the PCI to make strategy. Guide catheter should be considered as the primary step. Many a time, clinical judgment and experience is the key to select an ideal guide catheter, which will be safe and effective. Thank you for patient here.
Thank you, Dr. Shuvanan. I think both cases were, very illustrative of the, way to approach a lesion where you have, concomitant peripheral arterial disease, and of course, beautiful management of the complication on complication. So in the meantime, I'll welcome Dr. Balbir. He's just joined us, and hello, good evening to you.
Good evening,
Dr. Nikhil. Yeah, so I think we'll have a discussion on this. Would you like to start, Dr. Balbir?
Yeah, so Dr. Sumitra, I just want to know which company is selling papyrus stent, because we have not been able to get it.
Papyrus was usually introduced in Calcutta by Biotronic.
Yeah, it was available earlier. I've used one. I don't think it's available as of now.
Yeah,
no, it is not available now. They are stopped selling it. But we had some of the balloons, stents in our shelf, and we used one of them.
The papyrus is made by Biotronics. Unfortunately, Government of India considers it as a bare metal stent, and they insist they sell it at 8,000 rupees, which they are not willing to sell. So that is why they are not marketing it here.
Right. Because
the Abbott covered stent that is also available in 8,000. So we have to keep that because there is no other covered stent that is available in India.
Yeah, because the trackability of papyrus and the Abbott stents are hugely different. Papyrus is much
absolutely.
It's got a single layer of fabric, so I think that is the reason it is much.
Papyrus is like our regular stent.
Papyrus
very
is
good, very easily.
Actually, some of our society has to write to the government, because this can be a disaster if suppose an Abbott stent doesn't go there. You are in a total. You can lose a patient in the lab.
I agree with you, Dr. Balbir. I think if you have even a little bit of tortuosity or a bit of chunk of calcium downstream, your Abbott stent does not track at all. While
because
I have had a
recently
couple of
we had a problem, and then the Abbott stent didn't cross. So imagine there is a perf with a pigtail, the stent is not going. Then we had to use a guide liner, got the guide liner down the vessel, and finally managed to salvage the patient. But those few minutes can be such a disaster.
Yes, absolutely.
Very true. Very true.
So there must be a kind of a provision for a special sanction or something. I think
but when we started Plasties in '88, there used to be a lot of lectures on guide, active guide and passive guide, because those days stents were very bulky in 95 to 98. And to put those stents through a Shepherd Crook ride, you needed to have a wonderfully good support of guide. Now stents have become 62 micron and 65 micron, and we have much better quality guide. So the delivering of stent is not that difficult now.
Dr. Jagdish, the advantage nowadays of the use of the guidezillas and guideliners, because
those were not
much more easier. You can track them over a balloon so that you are safe in not dissecting the artery. So that makes your life much more easier than to use guidings like Amplards or the EBUs too often. So, but it's always a balance which has to be maintained. And I think one lecture for the juniors on how to engage the left main is so very important. When to inject, because these complications are preventable. It's not that they will happen. They are just preventable complications.
And also what I feel in small framed females of our country, particularly in the Eastern India, they're so frail and small. They are even EBU3 becomes large. We need a smaller guides perhaps.
Dr. Ray, I want to ask you one question. In this technique of nano crush,
please.
You place on the side branch the stent. You inflate the balloon in the main branch while you are pulling the stent back, right? And now, can you not miss the ostium? Because that is the important question. That what if you miss the ostium in such a technique?
We have never missed the ostium because we always take a one such smaller balloon. Like if your side branches, daughter branches are say 3, and your obviously your proximal vessel will be 3.5 to 3.7. Now, in a case where there is a 3 millimeter distal vessel, we take a 2.75 so that there is enough area in which the stent is pulled. So 1 or 2 stent starts is always inside the main branch. And also we found it in the bench test. We did different angle bench tests, and it is found in all angles. The ostium is never missed.
And the second thing is that it is always recommended that when you crush the stent, you use a balloon which is sized to the proximal vessel 1:1, so that you crush the stent very well. This is the recommendation of the DK crush technique.
Yes, and there we differ, because when I pull the stent balloon towards the main branch, the stent balloon hits on the proximal side of the stent, side branch stent, and I put I do the kiss. In the kissing balloon, if the two balloons, the side branch stent balloon and the main branch balloon, which is smaller, the overall diameter is 1:1.
That's interesting. Yeah. So I think we'll move on to the. Thank you, Dr. Shuvanan, and I think we move on to the next presentation, which is a complex left main angioplasty by Dr. Amit Gupta. He's an accomplished cardiologist, intervention cardiologist working with the Columbia Asia Hospital, Gurgaon. Dr. Amit?
Thank you so much, sir. I think there is something like network issue which is going on through my side. Am I audible, sir?
Yeah, you're audible.
Yeah. So it will be okay.
You need to share your screen.
Yeah, I'm just doing that. I think there is some sort of network issue from my side, sir. I'll just fix it up and then come back.
Sir, you need to unmute.
Yeah, sorry. So Dr. Jay Shah?
Yes, this is Dr. Jay.
Yeah, so Dr. Jay Shah is a senior interventional cardiologist at the HCG Hospital, Ahmedabad, and has a lot of good work to his credit. So can we?
Thank you, sir.
Yeah, so he will be talking about physiology and imaging assisted PCA of the left main coronary intervention.
Thank you so much, sir, thank you very much, sir, for those kind words. And without wasting any time, at the outset, I would like to thank Transmedia for giving me this opportunity to present my case in front of this august audience and all the stalwarts of cardiology. So my case is basically a physiology and imaging assisted PCI of left main. It is not a very exotic I would say it's a simple case, but there are certain things which we must remember while dealing with some distal left main or an ostial LED lesion. So 59-year-old female, hypertensive, recently detected diabetic, presented with an angina on exertion, which is crescendo in nature. Dyspnea on exertion, ECG was showing some STD changes, echo was normal, cardiac biomarkers revealed a little elevation in the troponin level, CPK-MB was normal, angiography revealed ostial left main, ostial LED, and rest of the coronary system was normal. The syntax score was 18. Now here, if you look at the lesion, it is exactly at the level of the ostium of the LED. And there is a trifurcating vessel that is ramus and circumflex, which both are, coming. So the plan was to go ahead and fix the ostial LED, but at the same time, when we are talking about this trifurcating lesion, we need to be very careful regarding the ostium of the rest of the vessels as well. So all the vessels, they were being wired with the help of run-through wire. 7 French EBU catheter was being taken. We did an FFR of LED, which is naturally, it is supposed to be positive, and it has turned out to be 0.69. And then we plan to go ahead with the IVUS of that particular artery. You can see that diagonal and the septal, they are entering into the left anterior descending artery, then the healthy zone of LED, which can be easily visualized. In the panel B, you can see that as we are coming closer to the ostium, you can see that the ostium is really narrow. There is a high burden or a very large burden of atheromatic plaque. And this is the 2 wire which are entering into the left main. And you can see that the distal left main is also having an eccentric lesion at the level of distal left main. And then it is extending just beyond the shaft of the left main. The ostium of the left main is very healthy. So the plan was to look for the proper imaging, physiology, and then decide the planning by going ahead with the intervention, whether to go ahead with the left main to LED or to protect by protecting the rest of the vessels. So in nutshell, if I tell you, LED ostium was very critically ill with a plaque burden of around 70%. Distal left main is already having a plaque burden of around 48%. And the left main plaque was, the left main per se, the artery was around 4.39 millimeter. And if you look at this particular, the IVUS, you can see that since it is an ostium of the LED, it is looking a fibrofatty or rather a little firm ostial lesion, which requires ostial cutting balloon technology. So we did a 2.5 by 8 millimeter flextome balloon at the level of the ostium. And then it was being dilated at a pressure of around 12 atmosphere. And then straight away we took a stent, which was being inflated at the left main to LAD region. The stent deployed was 3.5 by 23 millimeter. It was an expedition stent. The stent was, the pot was being done because as we did IVUS, we knew that the ostium and the proximal part of the left main is almost around 4.4 or 4.5. So we took a 4.5 by 12 millimeter balloon for pot. Pot was being done with crossover, and you can see that there's a carinal shift, a little bit of pinching which was there at the level of the ostium of the ramus. And when we deployed a stent, we wanted to create one thing is that it should have a better expansion at the level of the left main, and it should have a good tapering at the level of the ostium of the LAD with a proper expansion at the level of the distal left main as well. So if you, if you see both this IVUS imaging, you can see that the stent deployment and then pot, which was being done with the help of 4.5 by 12 millimeter at the level of left main and 3.5 by 8 millimeter at the level of ostium of the LAD. It has produced a more uniform expansion of the stent. The stent is not having any malapposition. You can very well visualize both the wire which are entering into the left main, and the left main plaque is being squeezed with the help of the stent. The stent also, dilated properly, and it could gain the proper MSA after the deployment. So in both these images, you can see that the circular pattern of the left main and the stent was being maintained, and this was in the panel B, it is showing the ostium of the left main. This is the stent boost image of the pot, which we have done with the help of NC balloon. And if you look at the rest of the artery, as we have done FFR of the ostium of the LAD, after stenting, we wanted to see whether the ostium of the circumflex and the ramus, which looked a little bit of pinch because the carinal shift on an angiogram, FFR was turned out to be negative 0.93 and 0.99 respectively. And this was the final result, which is showing a proper inflation of the left main to LAD stent and a TME3 flow. So my take home is that the physiology and imaging, it has assisted our strategy in a great way. In such type of lesion where it is involving the ostium, it is always better to use a cutting balloon technology, which will help in preventing the plaque shift. And in our case, FFR and IVUS guided angioplasty, it has helped us to get the favorable long-term outcome. And if I can tell you the clinical outcome of this particular patient, the patient is being done in the last COVID, that was in April 2020, and last 1 year, she is being maintained on a proper antiplatelet, and she is doing a great job, without having any unwanted events, or she is keeping a very good physical activity as well. And the treadmill test, which was being done at the end of 1 year, is also negative. So thank you so much for the quiet listening. I am inviting any questions or any suggestion on this particular case. Thank you so much.
Jay, Dr. Kartik here. Nicely done case. But yes, I would have done a little bit differently. I would have used a higher diameter balloon in the LAD cutting balloon. You used a 2.5. I think it was a little bit undersized. At least I would have used a 3 cutting balloon. So if you see the images,
you are right, sir.
Not expanded very well in the ostium LAD. So if you had used a higher cutting balloon, I think the expansion would have been better.
The point is well taken, sir. It actually, retrospectively, we also thought that ideally we should have taken 3 by 8 millimeter cutting balloon, which can give you a little better debulking at the level of the ostium. Point well taken, sir.
So, I mean, okay, let's take it on from there. I mean, what size of a cutting balloon would you use, Dr. Parikh?
I would select 1:1. Whatever was he had done IVUS, so he knows the vessel size already. So I would take that size. 3, if it was 3, I would take 3.
So, Jagdish, sir, the eccentricity of the lesion at the level of left-handed descending artery, and especially when we are using a ostium with a cutting balloon, where the internal dimension is almost 1.4 millimeter square, using a 3 millimeter balloon without pre-dilating it with the help of either a semi-compliant balloon, would it change the scenario, or will it be okay like straight away going ahead with the higher pressure, higher cutting balloon?
I never take cutting balloon as a first balloon. We always pre-dilate, and then you have done imaging, so you know the correct size of the vessel. So then I will select the 1:1 cutting balloon, and I generally avoid very high pressures on the cutting balloon. And after that, we will put a stent. And so then
yes, sir. So
I hope that, I have answered.
Yeah. So by doing that,
important. Yeah. Sorry.
Please, sir.
This is a very important suggestion by Parikh sir. That if you see the inflation chart of the cutting balloon, if you go high pressure, it becomes a compliant balloon because it is nylon. So basically, you cannot go, except in Wolverine, which is a different balloon. In the flex storm, you cannot go very high pressure unless you take a one size smaller balloon. In a one size smaller balloon, you can go to high pressure, and you have to, understand that it will be, inflated much more than what is needed.
So actually we did a 2.5 by 80 millimeter balloon, and we went up to 12 atmosphere. Usually with cutting balloon, we hardly go up to maybe 8 atmosphere is by and large higher pressure.
8 to 10, yes.
Yes.
My dictum is very simple. For OPN balloon, half size smaller and high pressure. And for cutting balloon, 1:1, but not very high pressure.
Right, sir.
And what I want to ask you, did you use standard for left main into LED? Then did you do kissing and open one strut into the SIR? Because if you need to do future any intervention in SIR, you have kept a strut across the mouth of the SIR.
Sir, the strut, we did a pot, sir. Pot was being done with the help of
key?
No, we have not done kissing.
I would strongly recommend for left main SIR, any other bifurcation, you may not do kissing. But left main LED, you must open one strut to the SIR.
But just because of the fact that we might further injure the ostium, we did a FFR of both the vessels.
It will not be high pressure.
Okay.
Nominal 10, 12. And what I do, I put a short balloon, NC balloon in the side branch and short NC balloon in the main branch. We inflate the side branch first up to 10, then come it down. Then we inflate the main branch up to 10, 12. Then we inflate the side branch to 4 and the main branch to 12 and deflate simultaneously. So always you have access in future for the
circumflex.
For left main circ, you always do that.
Parikh sir, in the consensus statement of European Bifurcation Club, 15th consensus statement, they have not, they have said that it is inconclusive. You can do it.
Now not.
Hello,
now
sir.
Not for left main, sir.
Yeah, Dr. Refai Showkathali here. Can I just tell my point?
Please.
Yes, coming to the European Bifurcation Club, there's a nice article published in February of this year.
Correct.
The recommendation for provisional stenting should always followed by kissing balloon inflation of the side branch, particularly as we said in left main stent. So if you look at the EBC main study, which was looking at the provisional stenting strategy versus double stenting strategy for left main, it is mandatory to cross over and cross the wire on the side branch and do a kissing balloon inflation. And that, so the success of the procedure of even in provisional strategy is not successful unless you recross the side branch wire and do a kissing balloon and report it. So they have a very strategic way of doing left main bifurcation, even in provisional strategy. I agree with your point that there's one study we looked at the doing either kissing balloon or not, didn't show any major difference, but that was for long-term outcome. But now what they're saying is for left main, please, even if you do provisional, please rewire and cross and do a kissing. But as rightly said, it should be the shortest balloon we have to use. The more and more the kissing we do, the recommendation is go for the shortest balloon, because that's where the proximal vessel damage is lesser with shorter balloon than the longer balloons.
So let me add something very important. So kiss or not to kiss is still a controversy. It is not as simple as what has been said.
I would not agree with that.
I also don't agree.
I would not agree with that. The EBC is, as you rightly said, is one of the best clubs.
You have not let me complete my statement.
So
you have not let me complete the statement.
Sure.
So just let me give a chance. I gave you a full chance to speak. Now, even in the EBC main, only 75% ended up with kissing. Now, if you do an FFR, the consensus statement has also written this clearly, that FFR is a great technique to answer this question. If you do an FFR and find this, you may not need a kiss. Now, what is the importance of a kiss in left main? The importance of a kiss is not that you are grading excess for later intervention. If you do an FFR, this patient should not have many problems. The problem is, if you do an OCT in this case, you have to see on the side branch how many links are there on the mouth of the side branch. If there is a link and lot of metal, what happens is there is healing on the metal edges. And this healing creates 2 or 3 orifices on the mouth of the circumflex. This diagram is also given in EBC. And EBC does not say that you have to do a kiss. It doesn't say that. It still says that there is something to wait for. And to wait for is to look at FFR, to look at what happens, this OCT, if you do an OCT, how many struts are there? If there are too many struts, if there is a link, better open it, because they could heal later on with the sieve-like restenosis. So that is what EBC is saying. It is not saying, and EBC main is a beautiful trial where even 25% people did not do a kiss to the left main after a provisional stenting. So this topic is not closed as yet. I agree that
I got the EBC main paper in front of us, sir.
Okay.
The kissing balloon inflation in stepwise provisional is done in 89%. 89% of the cases, out of the 230 cases, they've done kissing in provisional strategy in 202 patients. Because I know, because it's mandatory on this protocol itself, how to do a provisional strategy. So they're very clear about it. So they clearly said, I mean, as you rightly said, the FFR will not give an answer to the question of your restenosis. The FFR is telling you that you have a good flow in the side branch. That's all it's telling. It's not going to give an answer about the recurrent TLR rate. The main reason for doing the kissing balloon is to reduce your TLR. That's the only reason they were advising kissing balloon inflation after provisional strategy. But I agree. I think there is no clear data as such to confirm one way or other. We all agree with that. But the consensus statement from EBC, the recommendation now in 2021 February guidelines, just before the EBC main, is if you're doing a left main provisional strategy, always finish with the kissing and then report it, and that's the end of story. But I agree, EBC main had the mandatory thing, but even then 89% of them had kissing balloon inflation, even in provisional strategy. I agree with that. I think the 11% didn't have it. But we cannot say that it was an issue, but there's no clear data for that.
So we got
the other thing, important point in this case is that it is not going to be a kissing. It has to be a tris in the case because the ramus is quite big. So this case is not as simple as just a kiss to the circumflex. There is a huge ramus coming in. So you need an 8 French guiding to do a tris in this patient.
Or you just do one branch. You just make sure that you move the struts away from the branches. That's the whole idea, right? I mean, just to move it from the carina as much as possible. The whole idea of kissing is to move the struts out of the carina to prevent re-narrowing in the future. That's the main thing.
So I think that is a great discussion on this subject. And I think Dr. Balbir had some good practical points. And I mean, okay, apart from the theory. And I think we move on to the next presentation. And
thank you, sir.
Yeah, thank you, Amit. I think Jay, you brought on some active discussion on the subject. The next one is
it's an excellent case, actually.
Yeah. Thank you, Doctor.
A lot of thought-provoking, comments. Yes. So Dr. Jimmy George is a senior intervention cardiologist at the Lizzie Hospital, Cochin, and may I get him to come on? So incidentally, the first left main intervention was done also by Andreas Grunzig, and in an initial series of almost 50 cases which he presented, and all of them were COBAs at those times. And the first left main intervention done by him was in 1978. Yeah, please proceed, Dr. Jimmy.
I think you need to unmute, Jimmy.
You're muted, Dr. Jimmy George.
Please
Okay.
unmute.
Yeah, that's better.
Yeah. So after a nice presentation by Dr. Jay Shah, my case also is a trifurcation. So I'll just go with the case history. This is a 54 years old gentleman with an effort intolerance of 2 weeks, now progressing into rest symptoms. His ECG and echo was unremarkable. He had a good LV function, but his troponin was positive. So we took him for an angiogram. And this was an angiogram which was showing a mid-distal left main shaft narrowing, followed by a trifurcation with a very huge ramus, which a distal bifurcation lesion at the distalmost part. The LED proximal also has a borderline 70% lesion, distal free of disease. The diagonals have some diffuse disease. The circumflex looks like around 2.5 mm vessel. It's free of disease. That's again a caudal view. You can see the distal left main narrowing, the proximal left main free of disease, RCA dominant free of disease. So what are the options for this patient? We got a distal left main involving with the proximal LAD involving a huge ramus with a distal disease, and the carina sometimes looks most like a free of disease. Shall we go conservative? But he has come with rest angina now, troponin elevated. Bypass surgery, another option because of the trifurcating disease. Angioplasty, well, a good option also. But if you're planning for it, is it a provisional one? Is it a bifurcation one? Or is it a trifurcation one? So all those things, should we physiologically assess the lesion before going on with a conservative or revascularization procedure, or imaging has any role? So all these things were there. So I thought I'd go with an IFR first, followed by an FFR. Adenosine was loaded, but an IFR wire was passed. And let's see the physiology, how it reacts with. I'm not starting with the mid-LAD lesion, it's an LM session. So that's the distal LM and the proximal. You can see the step-up seen at the proximal part. And IFR was almost 0.81, which was quite taken by a surprise because I was expecting it to be in a borderline lesion. And if you can see the step up also in the proximal part of the LAD and the left main also seems to be quite huge. And if you can see the co-registration part also, which I'll just come up, you can see the increase in the at the distal left main and the proximal LAD seems to be quite a significant one. So let me just confirm it by an imaging also. This was a run from the distal LAD to the proximal lesion. Sorry, this is the mid lesion. It's a co-registered one. Sorry, quite a lengthy run. Sorry for that. And now comes the proximal part of the LAD. Seems to be a significant stenosis over there. Followed which now comes the carina part. That's the carina where the ramus wire is there. Followed by the tight mid lesion in the left main and the proximal LAD. Sorry, proximal left main. So I'll just, this is the mid LAD run to see that mid lesion in the mid LAD. That also seemed to be quite significant in the first run. So another run was taken across the mid LAD to see the LAD lesion. So the measurements show that the mid LAD is of 1.45 lumen area. The mid shaft or the proximal mid part of the LAD, there also you can see a calcification, but less than a quarter calcification over there with significant thickness. That is at the distal left main or the mid shaft. 3.67 is the MLA, and if you can see on the proximal LAD, sorry, proximal left main, it's around more than 10.5 to 11. And if you see the Carina view, it looks like almost, it's not a trifurcation, it's looked like an early OM coming up from the circumflex. You can see both the openings of the circumflex and this is the ramus opening where the wire in the ramus was there. So now we have got a discrete significant left main lesion in the mid shaft. The proximal LAD also is significant. The ramus, which was supposed to be a large vessel, looks like an early OM. So you got a lesion in the proximal LAD, you got a lesion in the distal LM or maybe in the mid shaft LM, and the carina looks free of disease, may or may not, but not significant burden of disease in the carina. So I'll just, the same values at the left main also, I'll just come up. This is at the point of the lesion of 3.89, the proximal LM around 8 and more than 11 around the proximal part or osteoproximal part of the left main. So what could be the strategy? Should it be just a provisional single stent like what was discussed, an LM-LAD stent followed by a pot and opening the struts towards the ramus, kissing over there, followed by again opening, maybe after a pot, opening the circumflex and do a triple kiss. All these things were the strategies planned. So the mid LAD was pre-dilated, followed by the proximal LAD and left main pre-dilated with a 3 balloon. This was followed by 275 48 drug-eluting stent deployed at the mid, followed by a 428 drug-eluting stent deployed from the LM-LAD crossover. So this was post-dilated with a 3 balloon. And let's image it up and see what the stents look like or the carina looks like. This is from the LAD to the left main. Seems to be that's the overlap area of the mid LAD or the proximal LAD, and now comes the carina part. That's the wire which comes up from the, it's a jail wire. So you can see the struts across the carina, which is open up there. As we saw in the carina view, it's just one opening with an early OM bifurcation. Sorry, a lot of blood over there, not a good view, but I can see the struts across the carina. So a recrossing, this was a recrossing wire with the jail wire at the side as a marker. There you can see trying to cross. There seems slightly an intermediate cross. So thought of crossing some more distally. That's an attempt to cross more distally. That's a distal cross, but otherwise looks like a distal cross, but definitely that needs to be confirmed. So that's a confirmation by, again, OCT, where you can definitely see the wire coming up distally up there. I would take a carina view to confirm it, that it's a distal cross. Now these struts across whatever ramus or whatever OM and circ is there needs to be crushed or needs to be sidelined. So this was followed by a 315 and a 275 15 balloon. So you see, not crossing much of the ramus, just at the proximal part only. And a soft kiss followed by individual dilatations, and definitely confirm that by a final OCT. That's a run of the final OCT where you can see a well-deployed stents, and that comes a carina. Seems few struts, but I think it's always better with a bifurcation view to see the struts opened up. You can see well opened up struts there. Some crowding at the ostium part of the circumflex. And a final part with a 4.5 balloon, and that was a final angio result. And that's a final fly-through view where you can see from the 12 o'clock to 3 o'clock where the carina seems to be free of struts and well opened up. And if you see the areas also in the distal left main, 10.5 post-standing, 10.8 at the mid shaft, and more than 13 around at the osteoproximal part of the left main. Conclusion, I would say imaging is a cornerstone for any complex PCI. Physiology definitely adds to it. Bifurcation, trifurcation, carina assessment is quite critical, and wire crossing also better confirmed by imaging. Struts are connectors, and struts and the connectors are the key for restenosis. and definitely need to be removed. And imaging makes a complex PCI quite simple. Thank you.
So Nikhil, I was pointing out these struts. Thanks for bringing out this case. So when the struts are seen on the osteum, this is a chance of healing with sieve-like restenosis. Now I'll just read out the EBC March. It says when to perform side branch dilatation due to distal left mains provisional stenting. Very clear. So whether to perform side branch dilatation after unprotected provisional stenting in daily practice is a matter of debate. According to the provisional strategy, if there is a suboptimal result on the side branch, a kissing needs to be performed. However, if there is no suboptimal side branch result, if it looks optimal side branch on the circumflex, it is a debatable issue. Floating struts across the osteum may lead to a development of a fenestrated restenosis in long term. Contrary to these concerns, a large registry of patients treated with crossover stenting from left main to LAD has demonstrated a 5-year incidence of TLR was not different between those who are kissed or not kissed. So the debate on optimal circumflex after a provisional stenting, whether to kiss or not, continues. This is EBC March this year.
So can you please also read along the line? In few more down the line, you will see, however, as a consensus, we agree that doing a kissing is recommended. If you just go down a little bit, because I've also read the document very carefully. Yeah. If you go down a little bit, you can read that.
So it is consensus of experts, but the data doesn't favor it. So this continues to be a debate which does not have a final answer, clearly doesn't have a final answer. At the moment, if you see so many struts that were seen on the circumflex osteum, like in this case, which we also follow very carefully, that we look at the osteum and the struts that are hanging on the strut. If there are too many, we should put them without a clear-cut answer to this question. So we don't have a good answer to this solution at all.
So I think
I totally agree with you. There is no clear.
I think the jury is still out. I think we'll leave it at that. And I haven't heard from Dr. Chandwani. So, sir, are you there? Sir?
Yeah.
So could we have a couple of comments from you?
Yeah, basically, we are also following, Dr. Balbir is absolutely correct. We are also following the same strategy. In all the cases, particularly we are doing the OCT. If OCT is not showing, if OCT is showing there is no strut or only one strut, then we are not doing kissing balloon. If OCT is showing more than one strut, then only we are going for the kissing balloon.
Great. So, and any of the other panelists, we haven't heard from a lot of people. They've been on the. Any comments?
No, I agree with the point that if the OCT is nicely showing the struts are not covering the osteum, yeah, you don't need to do it. But not everybody does OCT in left main. Some people do IVS, you know what I mean? So IVS may not be very clear in showing that struts in the osteum.
I think if you are using only one stent strategy, always do this OCT. It's always better.
Connectors are a point where you get a lot of restenosis. So that just has to be completely removed. And if you have less connectors, like stents where you have only 2 connectors, that is always better when a bifurcation you put it out. So that the chance of getting a connector in between, even if you don't doing image, will be very less.
So great. So I think we'll move on to the next case with Dr. Suseenth Kanna. He's a consultant intervention cardiologist at the NG Hospital and Multi-Speciality Center in Tamil Nadu. And may I have your case, sir?
Last case. Can I stream my slides, sir? Sir, can you see my slides?
Yes, we can see your slides. Can you move on to a slideshow mode?
Yes, sir.
Yes.
Good evening to one and all, my seniors and my senior colleagues. I'm presenting on 3 cases. Actually, I'm going to present, sir. First case is a 38-year-old gentleman, known diabetic and hypertensive. He had an anterwall enstomy in 2019, and The angiogram done in outside center showed mild left main disease with moderate single vessel disease, and they was put him on optimal medical management, and he was asymptomatic for almost more than 1.5 years. In 2020 August, he presented with effort angina class 2. That time ECG showed a T-wave inversions in anterior leads. Echo showed mild hypokinesia of anterior wall with good LV function. And this time angiogram done, which shows a mild left main disease with significant LAD disease and mild Ramus disease. And this is the guiding catheter 6 French done in a radial approach. Shows proximal LAD, proximal and mid LAD has significant more than 80 to 85% stenosis. Left main is actually a mild disease, that's around 20% stenosis, and Ramus proximal segment has 30 to 40%, and circumflex is free of disease with the angulation of more than 90%. And I plan to do LAD stenting, sir, these patients. Run through wire was crossed, and lesion was pre-dilated with 2.75 into 10 millimeter NC balloon. And I plan to cover from the ostium till the mid segment. I used 3 into 38 mm drug-eluting stent. After a drug-eluting deployment of the stent, then I used 3.5 into 10 mm NC balloon, and I post-dilated at around 16 to 18 atmosphere in the mid segment, and proximal had gone up to 22 atmosphere. And stent boost shows clearly, because this patient I didn't use imaging modality, because I planned for only LAD stenting, so I didn't use any imaging modality there. This patient had a mild under expansion in the ostial segment. Then I used 3.5 NC balloon, gone up to 24 atmosphere. Then I'm happy with the way that LAO-caudal view shows there is a good expansion of the stent, and the other vessels are not pinched, and there is no carinal shift. I'm happy. Then I took multiple views. The left side, you can see some mild haziness in the proximal portion of the LAD, as well as this time I took multiple views in RAO-caudal, AP cranial views, and in LAO-caudal views. Then I noticed LAO-caudal views, there is a staining at the, you can see the staining in the left main. Then this time I used 4 into 24 mm drug-eluting stent to overlap in the with the LAD. Then I post-dilated with 4.5, 4 into 8 mm balloon, as well as I used 5 into 8 mm NC balloon at the left main. Then this shows a clear good expansion of the stent with the TIMI3 flow. There is no carinal shift. There is no flow limiting disease into the ramus as well as into the circumflex. And this shows a good expansion of LAD ostium after my second post dilatation. And this left main is well expanded with the stent boost, and there is no residual stenosis. And is on follow-up for 6 months duration, is doing well. There is no effort angina after that. And this is my second case. A 66-year-old lady, a known diabetic, hypertensive, dyslipidemic, and obesity. She had an anterwall MI in 2017 and diagnosed to have double vessel disease, and she underwent ad hoc PTCA to LAD in some other hospital in 2017. She presented with effort angina in 2020. That time showed a triple vessel disease with a critical stenosis in the circumflex and RCA, and moderate to instant restenosis of LAD. She underwent successful PTCA to LCX and RCA in August 2020 in my hospital. And after a period of 8 months duration, she presented with recurrent angina, effort as well as rest angina. This time shows circumflex and RCA stentis pattern, and there is a critical instant restenosis in the LAD. I gone into the femoral approach because of tortuosity in the radial approach, as well as the very spasm. She's obese lady, but vessels are not that great, so we underwent PTCA through the right femoral approach. And OCT are done in this patient, which shows there is a fibrocalcific lesion, as well as there is a under-expansion, because the stent which was used previously is 2.5 into 24 mm in the proximal segment, and they not done a post-dilatation during the ad hoc PTCA. And there is a fibrocalcific lesions, as well as there is a clear-cut under-expansion of the stent, and distal diameter is around 2.7, the proximal diameter is around 3, and there is a mild under-expansion of the previous stent, and neointimal hyperplasia with critical stenosis with MLA of area of 1.4. Then I pre-dilated the lesion with 2.5 mm NC balloon. Then I do a check shot, shows a good expansion of the instant restenosis. Then I used 3 into 33 mm drug-eluting balloon, Zine's expectation I used in this patient, and I gone up to 12 atmosphere. Then I used 2 NC balloon, that is 3 into 10 mm in the distal portion, as well as 3.5 into 10 mm NC balloon at around 18 to 20 atmosphere in the proximal segment. And this is the final result with a pinching of LAD, pinching of diagonal branch, but there is a good 3-3 flow. I don't want to cross the diagonal branch, so just I left. Then I done a OCT post-stenting, and there is a good expansion of the stent. There is no malapposition, and some mild tissue prolapse is there. Other than this, the good expansion of the stent throughout the stented segment. Coming to my third case, a 66-year-old gentleman, known diabetic dyslipidemic. He had antrovalema in 2018, diagnosed as double vessel disease, and he underwent successful PTCA to LAD bar LCX in 2018, done in my hospital. He had effort angina in 2021 after 3 years duration. Angiogram showed a pattern stent in circumflex and instant restenosis of LAD with 80% stenosis and critical stenosis in the ramus. ECG showed TV inversions and anti-relates. Echo showed mild LV dysfunction with hypokinesia of interval and apex. This shows a subtotal occlusion of the ramus, and there is a significant stenosis in the instant restenosis in the LAD. And a run-through wire was crossed with the EBU 3.5 catheter, and a small balloon dilatation done to the ramus because of small caliber vessel, and it's a good 3-3 flow achieved in the ramus. Then OCT done in LAD, because the previous stent which I was used is 2.75 into 28 and dilated with the 3 in 2018. So this OCT run shows that there is a thick fibrocalcific lesion, and it's a good expansion of stent, but there is a thick fibrocalcific lesions around. R calcium is there, as well as a thick fibrotic lesion in the stented segment. Because of, I think I used a 3 into 12 angiosculpt balloon, because I thought of the fibrotic lesion. I used an angiosculpt balloon here, 3 into 12 atmosphere, 3 into 12 mm angiosculpt with 14 to 16 atmosphere. Then I used 3.5 into 33 mm drug-eluting stent from ostial LAD into the mid LAD. Then I post-dilated with the 3.5 mm into 12 mm NC balloon around 18 to 22 atmosphere. Then I imaging that Cine shows a good expansion of the stent. Then the OCT done post-stenting. OCT shows good expansion of the stent with adequate areas achieved in the distal segment as well as in the mid segment. And at the ostium, the stent has mild, this malapposition is there at the ostial LAD. Then I used a 4 into 8 short balloon in the ostial LAD around 10 to 12 atmosphere, and this is the final result. A stent boost shows a good expansion of the ostial LAD stent. So conclusion is then in my case one, there's a ostial stent was underexpanded with a stent boost. After a NC balloon dilatation, there was a proximal edge dissection, and I did a left main to LAD stenting was done successfully. After multiple views, after giving NTG and Corandil, I wait for few minutes, and then I did multiple views. Then I noticed there is a dissection, and I didn't use imaging for the patient, so I used a stent boost as a stent boost, and optimal results were achieved. In the second and third case, a reason for instant restenosis was identified with OCT, and adequate lesion preparation was done with NC balloon as well as the angiosculpt. Proper stenting, proper sizing, as well as the optimal results were achieved with imaging guidance. Thank you.
Yeah. So thank you so much for your three cases. Can we invite the panelists? Dr. Chanana, are you there?
I would like to make a comment.
Yeah, sure, please.
Yeah, very nice cases, nicely done. In the second case, I would like to comment because it was a restenosis and your OCT showed a distal diameter of 2.75 and proximal 3. You used just a 2.5 NC balloon. I think you should have done a cutting balloon with a 3 at least, or later on you could have gone with an NC 3 balloon dilated, because if you look at the luminogram, the OCT run, the final image is, the expansion is just 77%. Whereas the third case you showed, the luminogram before the pre-OCT, pre-stenting, it is 82% and the post-stenting is 104%. That's the ideal result to achieve with OCT. But if you look at the second case, the final luminogram shows only 77% expansion. Now the standard is it has to be more than 80. So you had the advantage of OCT. I think you should have optimized it a little bit better in second case.
Okay, sir.
Yeah, I think you should have gone with a higher balloon.
Because after using a 2.5, I took a shot. The finish looks okay. So then
what you got very good information on OCT. It was an underexpanded stent. So you should have expanded it with a 3 balloon nicely before you put the second stent. So once you prepare the bed very well, expand the first stent which was underexpanded, then the result would have been totally different. Now you put the second stent in an underexpanded stent without dilating the first stent. So obviously it's suboptimal because the luminogram clearly shows it is 77% expansion. It has to be more than 80. Yeah.
Dr. Kamal, are you there?
Yeah, hi. I completely endorse the comments from the previous panelists. So, am I audible?
Yes.
Hello?
Yes, you're audible, Dr. Kamal.
Yeah. So I completely endorse for the second case what the previous speaker is saying. Otherwise, three beautifully done cases. Again, I sometimes feel the OCT in the left main and the proximal settings can sometimes be, dicey enough. Actually, imaging with an IVUS may probably be a better strategy if you're doing a dedicated single stent strategy.
Regarding the first case, Dr. Balbir, would you have done something different?
Hello. Yeah. So I would little bit disagree on the left main business. So left main is of 3 parts. So as we know, ostium, midshaft, and distal bifurcation. So if we compare OCT and IVUS for left main, distal bifurcation is clearly very well delineated with OCT because you have the whole carina well defined. You have all your numbers correctly defined. And as we discussed about the circ ostium is very well defined. So is the midshaft. Is the ostium which is the problem. And the ostium is missed by OCT several times, though there are some techniques to look at the ostium also. But clearly for ostium, IVUS is far superior than OCT. Nikhil, I missed the first case, so I saw the second case.
So just tell me, there was some reading that there is a size cross-sectional area size.
Okay, so we were a part of. So we were a part of the Illumin 4 trial. So I enrolled the maximum number from our country. In the Illumin 4 trial, the mandate was that you have to achieve a MSA of 90% of the reference size. So the stent was divided into two halves. So the distal reference and the proximal reference were calculated, and it was mandated that you reach 90% and above. The truth is that they did not allow us to oversize the balloon. So the balloon in the distal part was according to the distal reference diameter from media to from the EEM to the EM, but you were not allowed to increase the size of the balloon, because if you do that, you have a chance of rupture. So the maximum balloon used was that, and the maximum pressure used was 20 atmospheres. So if I tell you my data, we had 65 patients, and in almost 30 patients, we could not achieve 90% MSA. And in about 8 to 10%, we could not achieve 80% MSA in the vessel. So it is a vessel compliance which teaches you that you may not, with the use of IVL and use of rotablator more frequently, maybe we will have less numbers of patients who will achieve these figures, but it is not possible to achieve these figures in all patients, whatever you may do. And oversizing the balloon to more than the reference area can actually be catastrophic. So you cannot do that.
Yeah. One more point I observed is your third case, excellently done, very good result. You towards the ostium, you had 2-3 red markings on the OCT. That usually those are the studs which is across the circumflex. It doesn't mean that it is underexpanded. So when you see the studs across the circumflex ostium, they are hanging there. So there's no need to go and post dilate with a bigger.
Yeah,
balloon.
correct. Absolutely correct.
Those are that nothing to worry. That's because of the machine. It gives you the wrong color coding. You know. And your third case was absolutely fantastic. Very good.
Final comment.
I have a small
Jagdish?
question to Balbir.
Yeah.
As because in Adobe DAs, they took the media to media and they said that 80% achievement of the area would have been successful. What is your opinion about that?
So
if you take in the external elastic lamina, it would be slightly oversized. What is your
So if you compare IVUS media to EEM, they're practically similar. The studies have shown they're practically equal. If at all, IVUS will be little higher than OCT. But if you take the newer IVUS machine, the higher frequency machine, the OCT and the IVUS values are exactly same. There's no difference.
Okay. Thank you, everybody. And let's move on to the next presentation. Dr. Refai Showkathali, are you ready?
Yeah, I'm ready. Let me just show my screen. I hope you can see my screen.
Yes, sir.
Yeah, thank you so much. Thanks for the organizers to let me speak on this forum with the eminent cardiologists from all over India. So I'm going to talk about left main bifurcation PCI with the DK crush under OCT guidance, assisted by intravascular lithotripsy and IABP support, which I presented at the EuroPCI this year as well. Oops, sorry. So, I mean, just a brief introduction of how left main bifurcation imaging is so important. This is a data from 2018, how nicely when you don't do imaging, you look at certain things, and when you do imaging, how things changes, that most of your bifurcation becomes 1-1-1 Medina, around 62%, even when you think that the normal angiographic images doesn't say that. In fact, some of them, 0-0-0 Medina, but when you do the imaging, you tend to find that 62% of the patients have 1-1-1 Medina classification. So the distal left main imaging is critical. And as we discussed before, and time again, when it comes to distal left main, OCT wins over IVUS. And with that, I'll just go to my case. So this is a 75-year-old gentleman with diabetic for more than 20 years, hypertension for more than 15 years, had recent onset of angina for 2 months. His resting ECG did not show anything significant except his previous hypertension showing left ventricular hypertrophy. An echocardiogram showed a good left ventricular function, no regional valve motion abnormalities, a little bit calcific aortic valve with a mild aortic stenosis, the peak mean pressure gradient of around 15 and peak pressure gradient of around 26 and AR, minimal AR. and he underwent a treadmill test by this local cardiologist, which showed a positive for inducible ischemia at stage 2. So he's a reasonably fit and healthy guy, except that he has quite long-standing diabetic and hypertensive. So he underwent an angiogram in November of 2020 in that particular hospital. And this is what we have been shown by the patient after a few days when he came to see me. So clearly you can see this is the caudal view showing the Medina, at least 011, maybe 111. So it's like a true bifurcation lesion involving, this is a dominant left system. As you can see, the right coronary artery, the angiogram done there was showing a rudimentary right coronary artery, very tiny, and therefore there is quite a large circumflex branch which has got an osteal disease, and you can see a reasonable size OM as well has got some disease on the proximal, osteoproximal segment. So a syntax score came around the intermediate syntax score around 28%. And when we did the syntax 2, including his age, creatinine clearance, and left ventricular function, and then so on and so forth, we have a 4-year mortality is equal with CABG versus and PCI, around 8.6% in both. Having said that, we all know the 10-year data, the mortality, the hard endpoint of the 10-year syntax left main cohort comparing PCI versus CABG was not different at 10 years. So that's one of the reasons why we can consider a left main, particularly when you're looking at hard outcomes. But of course, we all know there is increased risk of TLR and target vessel revascularization with PCI compared to CABG. So when I look at the left main bifurcation, I normally go by this particular study called Definition 2 study, looking at whether you want to consider this is a simple PCI or complex PCI. This is a very good study from particularly from the United States, looking at the diameter stenosis when it comes to left main, anything above 70%, and side branch lesion length of more than 10 millimeter, with the 2 minor criteria, anything above mild decalcification and a longer disease like what I have in the circumflex side branch, I would consider this as a complex left main PCI. So in those complex left main PCI, I would prefer to go for a 2-stent strategy, even though the EBC now says slightly different, but we have a lot of concerns about the EBC trial as such, which we will go through in the next few times. So with that in my mind, I decided decided to go for a planned 2-stent strategy. So considering is a left dominant system with a small right coronary artery, and I was going to plan to do PCI to the left main, I put a intra-aortic balloon pump to start with through the left femoral, and then we went with a 7 French EBU guiding catheter, as you can see there, which is showing an angle of around more than 70 degrees. So one of the things you can also see the calcification involving the left main and the LAD, and one of the other reasons why we do imaging in left main to identify calcification, which may not be very clearly seen on angiogram because the lumen itself is so big in left main, we cannot identify the calcium very clearly on angiogram itself. So sorry, let's see, go back. Oops. Yeah, so I wired all three coronary arteries as we do in concluding. Considering the obtuse marginal artery was reasonable size, I wired the circumflex, obtuse marginal, and the LAD. And the first strategy I had was to just balloon that osteoproximal OM branch. I didn't have any major plan to treat that with a 2-stent strategy. My plan was always to do left main and to LAD and circumflex. So 2.5 balloon inflation in all 3 branches. And when we did the LAD, you can see a gentle wasting noted at around 14 atmospheres. There is a wasting at the middle of the balloon, suggesting the calcification involved in that. You can also see the adventitial calcium on the coronary angiography as well. So after doing the ballooning, I did an OCT run, both through the circumflex, as you can see, pull back, and from the LAD as well. So as you can see, the kind of a mid LAD also has a significant stenosis. So the normal segment of the LAD is quite low down here, suggesting EEL of around 3, I think, if I remember correctly, 2.75 or 3. And as we all know, the OCT nicely demonstrated the calcium and the depth of the calcium. As you can see, the depth of the calcium is around 0.55 millimeter in depth, and 360-degree arc of calcium at the tightest portion of the LAD, and in most portions is around 180 to 270 degrees calcium. So having seen that, we all know the expansion of the stent is more important whenever there is a criteria of calcific length, arc of calcium more than 180, length of calcium more than 5 millimeter, and depth of calcium 0.5 millimeter above. The numbers are high, and therefore we need more debulking agents to make sure that you get a good result at the end, because we know all these three were noted to have stent under expansion leading to later stage TLR. So I straight away went with a 3 by 12 millimeter IVL at this mid segment where I could see the wasting first, and used around 20 pulses there, and then pulled back that balloon again at the ostium or left main to the LAD ostium, which is also significant calcium noted, and around 20 pulses there. So I had around 40 pulses for the LAD, and the plan was to do the circumflex for another 40 pulses. With that, I just took a check angiogram, which showed that there is no dissection or anything. So then when I went to do a post IVL pullback on the OCT, you can nicely see the cracks at the 12 o'clock and the cracks at the 9 and 6 o'clock, and maybe here. So it's around, the cracks are more than 180-degree cracks. So it's not in just one or two within the 180-degree, which is more than 180 degrees, suggesting that this will help you to expand your stent better. So the next step was after ballooning, and then I decided to stent the circumflex. As you can see, my circumflex stent was not going smoothly, so I have to use a guidezilla. And one of the things with the guidezilla is you can have a side branch wire if you are using a 7 French sheath and a 7 French guiding catheter. But when you want to get a balloon ready for my sequential crush, the guidezilla won't allow. So once I positioned the stent in the circumflex artery, I removed the guidezilla and got my 3.5 millimeter NC balloon in the LAD ready for crushing. So one of the recommendations is keep your crushing balloon ready in the LAD or the main branch while you deploy the stent, because you want to make sure that you pull back and do crushing without having any major issues. So a sequential crush was done with the 3.3, the LAD first, and then I went with a 4 by 12 millimeter balloon. This is also recommended as part of the DK crush technique to crush with your distal main branch size and then a proximal main branch size before you go for a first crossing over. So then I crossed the wire. So again, this is another issue. Sometimes we don't want to do multiple OCTs considering the age and the time. So I sometimes do is to do a nice stent boost with the balloon on the main branch and do a proper stent boost. Will give some idea, even though it will not clearly give the idea, but at least you can see the stent straight of the circumflex is here, and this is the crossover here. This is a proximal wire crossing. So we always want to do a proximal wire crossing in DK crush to confirm that. Either you can use an OCT, but if you think that you're doing too many runs, you can also do a stent boost to look at it. So you can see this is the other carina part of the stent, and this is the main muscle side of the stent. You can see the wire is crossing very closely. So with that, I did the first kissing balloon inflation. Sorry, the circumflex was a 3.5 stent. The balloon was also around 3.5 and a 3 millimeter balloon in the LAD. But having said the 3 millimeter balloon in the LAD, I went up to 8 atmospheres, whereas the first kissing balloon with the 3.5 in the side branch stent was around 14 atmospheres. So in fact, one of the things I did, as we all recommend, is to pull back the circumflex stent balloon after deploying the stent before the crush and expand it, make sure the ostium is fully opened. And then I went with a 3 by 28 millimeter drug-eluting stent in the mid LAD up to the proximal LAD, and then a 4 by 33 millimeter drug-eluting stent from ostium of the left main to the LAD as well. So as we all recommend, after putting the first, second stent, you always go for a port. I used a 4 by 12 at around 18 atmospheres, keeping the balloon, distal part of the balloon just at the level of the carina and not going too deep into. And this is the second rewiring. So this is either a mid or a distal recross is what the preferred choice. As you can see, this is going like this. Most of the times I tend to pull the LAD wire and drop it in the circumflex when you want to go for a distal cross, which is easier than coming back and going into the main branch. And the second kissing balloon was again with a 3.5 into the LAD. This time I reduced my circumflex balloon size to 3 and a 3.5 into the LAD, having deployed a 4mm stent. And then I used a 4.5 by 8mm for report. One of the good things of putting an ostial stent in the left main is you don't need to break your head on sizing the length of the port balloon, because you can always pull back. When you don't do an ostial left main, sometimes we don't want to do the ostial left main. You have to be very precise in terms of sizing the length of the port balloon, because we don't want to damage the proximal muscle. So this is the OCT at the end of the bifurcation view, as you can see, showing the circumflex ostium. It's taking a bit of time to open up. So you can see the circumflex ostium is reasonably clean. And in the two-dimensional view as well, you can see there is no stent strut at the point of convergence. And this is the left main MSA we achieved at this level of around 14.41. And there's a little bit more proximal left main. I thought slightly underexpanded, even though the criteria is around 300 microns is when you start to see the red flags, but it's around 200 microns. But nevertheless, having seen that, I just went ahead with a slightly higher balloon. I think it was a 5mm balloon. Again, the advantage of this is because I've got a stent from the ostium, I could nicely hang it out in the aorta and go high pressure, not even touching to the carina at all. So this is the final result of the, I think the next picture will show you. Yeah. So this is what we started with, and this is what the final result was. And this is a different angle of the at the end of the procedure. So the patient, this was done as a live case on an evening meeting like this. So by the time we finished, it was around 9:15. The patient removed the IABP the next morning, and the patient was discharged in 2 days. This is in November or October. I think it's November. So the patient is doing extremely well for the last 6 months. So in conclusion, severe calcification in the left main is considered to be one of the main challenges in left main bifurcation PCI. And that is the reason why imaging is so important for you to plan the procedure earlier on, rather than looking at an underdeployed stent at the middle of the procedure. So again, intracoronary imaging, I think the debate goes on whether IVES or OCT, but as we discussed earlier, except for the ostial left main, I think we can do OCT, which gives a little bit more better resolution, even though the 60 megahertz IVES is also showing reasonable resolution to show, but nevertheless, you cannot be able to see these bifurcation softwares are not available yet in IVES, whereas OCT has got all these softwares to look at the ostium of the side branch more clearly. And as we discussed, non-ostial left main OCT can be better assessed, particularly the calcific burden of where IVES won't be able to give the depth of the calcium, whereas the OCT can give you clear calcific burden. And we also have the criteria when to use debulking strategies with the calcium in the main arteries. Again, intravascular lithotripsy is an expensive option available at the moment, but I think one of the main reasons I use a lot of rote ablation, but I think when it comes to large vessels, we all agree that IVL is better in terms of plaque modification strategies compared to the other modalities available when it comes to larger vessels. DK crush is a challenging bifurcation technique. Again, coming back to the EBC, one of the problems of the EBC main, it's a fantastic trial, but there are the imaging usage is only 40% in EBC, even though in clinical practice, most of us who does left main will probably do around at least 90% we use imaging, whereas imaging was much less in EBC even in 2021. And the DK crush technique was used only in 5% of the EBC in the two-strand strategy. They mostly used culotte and TAP. The culotte was 53% and TAP was around 28%, whereas the DK crush is only 5%. But we have clear data saying from the DK crush 3 and the DK crush 5, suggesting that this is one of the best strategies to use in left main bifurcation PCI. Again, coming back to intratic balloon support is a support device in stable patient in left main. In my particular patient, he had a good left ventricular function, but still I used it purely because it's a left dominant system, and I'm going to be managing that for a long time. The case went on for around 2.5 hours on a live case, so the balloon pump clearly helped us to do the procedure in a more comfortable way than if you don't have a balloon pump. Again, the last slide to show the EBC, the differences between the EBC main and the DK Crush 5, that the IVUS use, this is not IVUS use as this is imaging use, 36% in EBC main and 4% of OCT, whereas in DK Crush, most of them are IVUS and 41% in. But you can also see that EBC main, there's a 1-year outcome is actually quite significantly high. Even in the provisional strength strategy, you see a higher rate of TLR, MI, and day. The definitions of MI was slightly different, and that could possibly contribute it. But nevertheless, if you look at the stent thrombosis rate, which is shocking in EBC main, is 1-year stent thrombosis rate, even in the provisional single strength strategy, is 1.5%, which I think even in our clinical practice, in 1 year, in left, particularly in a left main, when we use a large stents, we don't see that much of stent thrombosis. Of course, we all agree that the TLR and stent restenosis rate may be higher, but the stent thrombosis rate is quite high here. And the second point is EBC is just a 1-year data. Maybe if we prolong the data, there may be some benefit in the 2-stent strategy compared to the provisional stent strategy. I think with that, I will stop my talk and we'll open up for further discussions. Thank you for this anyway.
Yeah, thank you, Dr. Refai. I think a very elegant presentation, tad longish, but I think worth every bit of the listen. So I think we'll open the discussion. So Dr. Parikh, are you there?
I'll stop my sharing thing, yeah.
Yes. Dr. Parikh, are you there? Chandwani? Is anybody from the panel, any comments?
Yeah, Showkathali, nicely done case. Yeah, I just wanted to ask you one question. Do you use routinely IVP even in normal LVs?
Not really, no. No. This is the only reason I use for this gentleman is because of the right coronary artery was very small, as you see on the angiogram in the other hospital. I didn't do an angiogram at all of the right. It is extremely small. And having seen the calcium and the IVL as well, I wasn't entirely sure whether I may need a rotor before I cross the IVL balloon. So I just, on the safety aspect, I did. But there's no, as you rightly said, there's no evidence for that.
How much of a support? I mean, I don't think your IIBP gives you a very, very great. I mean, it used to. Of course, we all bank on IIBP. It's a very easily available, and it gives you a lot of peace of mind. But in a patient like this, I mean, how much of support does it give you? Would you consider using something? Okay, cost not withstanding, maybe an impeller or.
Yeah. Ideally, I would have used an impeller. If I have a choice, I would rather go for impeller. But unfortunately, that is not the option for most of our patients at the present time. Maybe in the future, we maybe when the cost comes down. But yeah, we all agree that all the trials comparing impeller versus IABP showed that it's much more the best technology available.
Yeah. Another thing which I observed is the ostium circumflex. It's naturally sealed. Always we tend to use a cutting balloon. Always do a cutting balloon whenever you're doing a two-stent strategy. And when you see the final results, I felt there is some slight under-expansion. I don't know. I didn't see
I didn't put the MLA, cross-sectional area there. No, I used IVL there. So
okay.
We used IVL there. So I used the 40 pulses in the LAD. And that's when I couldn't getting the IVL balloon through into the circumflex with that 90-degree bend was extremely difficult. And that's why I used to use a Guidezilla FAST to get the IVL balloon. And then I used 40 there and 40 in the LAD left. So
did you do a OCT pullback from the circumflex to L? Oh, that would have given you the MLA. I mean.
No, the second time I didn't. I agree with you because it's a long time. It's going on for 2.5 hours. Yeah. Ideally, we should do both pullbacks. Yeah.
Even the dye usage goes up. Correct. More number of.
Any more comments, Dr. Shuvanan? I haven't heard from you for a while.
I have a small point here. if your LV function is normal, and you know that your vessels are not that, you are not doing a rota or something, and how your IABP helps in this case?
I think we just discussed that.
We discussed already. I'm not completely telling that it helped me completely. Maybe it puts the operator at ease, thinking that if things goes down, the IABP helps. There's no evidence, as you rightly said. We discussed, yeah.
So it's like an Alprex without the sedation. So, okay, great. So I think it's very nicely done, and we'll move on to the next case. We have Dr. Kunal Mahajan. Is he there?
Yes, sir.
So Dr. Kunal Mahajan is at the Indira Gandhi Medical College, Simla, and he's the assistant professor of cardiology and an intervention cardiologist. Can we have your presentation?
Sure, sir. So is my screen visible?
Yeah. Must be lovely weather there in Simla.
It's really pleasant here. So I shall be speaking on management of L6 ostium in provisional LM-PCI, and we'll just start. And the major issues with management of side branch, that is LCX in provisional LM-PCI, majority of the things have been discussed in the discussion today. And I shall be focusing on whether we should go for a provisional versus two-stent strategy, when and how to do POT. Should we do routine kissing balloon inflation and remove struts across L6 ostium, as it has been really discussed in this meeting today? And I will show some cases. And is imaging mandatory? So provisional crossover strategy is a philosophy and not a technique. The basic aim is to keep the thing simple, and we can always switch to a two-stent strategy at any moment. Rather, if we start with a two-stent strategy, it makes the procedure complex from the word go. So we should reserve complex options only for complex lesions. And as Dr. Showkathali in his previous presentation described, that what is actually a complex bifurcation. For a left main, the lesion length more than 10 mm and a diameter stenosis more than 70%. These are the major criteria. Plus, we should have at least two minor criteria, that it should either the lesion should be thrombus containing, or the lesion length should be more than 25, severe calcification, or the unfavorable bifurcation angle. If you see the results of DK Crush 5 trial, where two-stent strategy was better with DK Crush, you can see that the lesion length in the side branch was 16 mm. And similarly, the definition 2 study, which also showed benefit of two-stent strategy, if you see, really 95% of the patients had lesion length more than 10 mm. So these are the complex lesions where, and in a meta-analysis, it was clearly proven that for lesions length less than 10 mm, provisional is definitely as good as two-stent strategy. And for lesion length more than 10 mm in the side branch, definitely two-stent strategy is favored. Now I will show some examples and how to use these criteria in our clinical practice. This was a 80 years old male with acute anterior wall MI and had a distal critical disease of distal LMCA. And you can see on the running images as well as the still image that he had a distal LMCA almost 80-90% stenosis, and there was total thrombotic occlusion of LAD just after a short stump, and LCX was also diffusely diseased, and he was having ongoing pain. We had to take him up for an PTCA, and this was in the caudal view. You can appreciate that there was a lot of calcification in the LAD and diffuse disease of LCX, and this was the result after we passed wire. This was after thrombosection plus diffusely diseased. We used imaging and decided our landmarks, and initially distal LAD was stated with a 3x40 stent, and then we deployed mini crush technique for LM to LAD and to fix up the circ, and all the steps were used, and this was the final result which we got. So it was a true complex lesion and had to be dealt with a two-stent strategy. This was the final result, and we optimized it with the IVIS guidance. This was another case where 53 years old male had presented to us with anterior wall MI, and again he had a very critical disease of the distal LMCA, and you can see almost 90% stenosis in the distal LMCA, and osteo proximal part of LAD is also critically diseased, and LCX ostium was diseased. You can better appreciate in this allocranial view, but it was a very focal disease. So here we had one of the major criteria, that is the lesion in the side branch was more than 70%. But it was a very focal disease. It was less than 10 mm. Only 1 to 2 mm disease was there, and there were none of the minor criteria were present. So we decided many people would start with a two-stent strategy in such cases, but we thought that it doesn't fit into a complex lesion, and here we can go ahead with a provisional approach, and that is what we did. We pre-dilated, passed wire in both the lesions, and ultimately put a single crossover stenting LM to LAD, and after that did a proximal optimization. Again, you can see the distal marker of the balloon is just at the level of carina, and after that we did a kissing balloon inflation and a report, and this was the final angiogram view. You can appreciate, and this patient has completed nearly 6-7 months follow-up now. He's doing well. These were the final caudal views. And we did a OCT also in this case, and it was a very well expanded and opposed stent, and we had no struts across the L6 ostium, and side branch orifice area appeared good. This was the third case which I want to present. This is a 65 years old female with NSTEMI. She presented to us and she had a diffuse disease of LAD starting from the ostium, and also she had disease of the ostial circ, but here the circ was dominant. Although the disease appeared only 60% stenosis, but it was a dominant circ. And here imaging, when we did imaging, we found that the ostial circ was there was a very tight disease. MLA was only 2.1. It's a very fibrocalcific lesion. So we again went ahead with the two-stent strategy because it was a complex lesion. We had used imaging for that and got a good result with DK crush. So a provisional upfront two-stent strategy is favored when there is a significant stenosis at the ostial circ and disease in the LCX is diffuse, at least more than 10 mm. If we are dealing with a large circ and left dominant circulation, or the angle between LAD and LCX is narrow. These are the situations where we can go ahead with a upfront two-stent strategy. Now let's see this case. It was a 55 years old male who had presented with anterior wall MI and had a failed thrombolysis, so he was referred to us, and this was his angiogram. You can see there was a very tight disease in the osteoproximal LAD, and also there was plaquing in the distal left main. This ostium of ramus as well as L6 appeared normal. RCA showed some plaquing in its proximal part, and we decided to use a provisional single-stent strategy across LM to LAD in this case, wired both LAD and LCX, and pre-dilated this ostial LAD lesion with a 2.5 into 12 mm NC balloon. And after that, this was post after the dilatation. And after that, we deployed a single 4 into 23 DES with at least 8 mm protruding into the left main for an optimal pot. And this is how we deployed the stent. And after deployment of stent, we did a proximal optimization with a 4.5 into 8 NC balloon. And again, the distal marker of the balloon is just at the level of carina, because if we place it too proximally, we will not be able to scaffold the stents towards the side branch, or if we keep it too distally, we will be causing the carinal shift. So we just kept it optimally at the level of carina so that we get a good pot done. And this is how a good pot helps, because if this is the picture before pot and after pot, you can see the strut, there are lesser struts in front of the side branch. So after that, we did a kissing balloon dilatation with a 4 into 8 mm balloon in the LAD and 2.5 into 10 across the ramus, and with a very short overlap, which is recommended that overlap should be at least less than or equal to 3 mm. And this was followed by final pot with a 4.5 into 8 NC balloon. And these were the final angio views, and we also did imaging for this. And this was the OCT image, and we have been discussing it that there should be no struts or links in front of the carina. And again, you can see in this case there were no links. In fact, LCX, it was not a ramus, it was early OM, and you can see it had a common ostia. So there were no struts in front of the side branch. So we had got a good optimal result, good expansion of the stent throughout, and there were no struts in front of the carina, which we wanted. And so this is a very controversial topic, that whether we should remove these struts in front of L6 ostium or not with KBD. And so far, no clinical studies have shown any benefit. And this is the result of 4-year follow-up of Excel trial. And clearly there was no provisional LM crossover stenting. There was no benefit of routine KBD. But unfortunately, they are not done imaging in all the cases. And Dr. Ronnie Matthews, he has clearly shown in his case series that if you leave struts in front of it, we all know this these days, that if we leave struts across the side branch ostium, especially across LCX, this is what can happen. We can have fenestrated restenosis because of new internal hyperplasia if we leave struts across the side branch. So if we have OCT, we should do that and see if there are any struts, we should remove it. So this is the last case which I'm going to present. She was a 65 years old female who had undergone PTCA to RCA in 2019, and now she had presented with class 3 angina and a strongly positive TMT. She came to us in this year, early March, and these were the two lesions which had progressed from the initial angiogram. RCA stent was patent, and there was no disease in RCA. This was a distal LCX disease which appeared significant, and also diffuse disease of LM and LAD was there, and disease was extending up to the distal LAD. You can see there was diffuse disease starting from the LM and it was extending into the LAD. But first we fixed the distal LCX with a drug-eluting stent, and there was no pinching of the side branch OM in this case. And after that, we assessed the disease in LM to LAD with both FFR as well as with OCT. And these were the FFR was positive, And then we took OCT run across the LED, and we found that there was a long diffuse disease of LM starting from the LM up to the distal LED, and it was a fibrocalcific disease. Importantly, again, we had to deal with one more bifurcation, that is distal LMC bifurcation. Here, the ostium of the circ was normal. We had already imaged that with OCT. But importantly, whether there was any chance of cranial shift, we could assess it with the CT angle, this cranial tip angle. This is the cranial tip angle. It was more than 50, and if it is more than 50, usually there are lesser chances of this cranial shift. And this cranial tip to branching point length, if it is more than 1.7 mm, also there are lesser chances of cranial shift. So both things were in our favor, and subsequently we prepared the bed initially with the NC balloon, then we used cutting balloon, and after preparing the bed adequately, we first deployed the mid-distal LED stent. 3x38 days was used, and after that we deployed LM2 LED stent overlapping the distal stent with a crossover approach across the LCX. And this was the immediate OCT run after deploying the stent, and you can see that clearly there were a lot of struts in front of the LCX ostium. So we had to deal with it. And so what we did, we first did a pot with a 4.5x8 NC balloon, again highlighting the fact that the distal marker of the balloon is just at the distal bifurcation point. That is very, very important. And after doing a pot, this was the picture which we got. There was some pinching at the ostium of the L6, did not appear significant. And then we rewired distally with the previous jailed wire as the marker. And we were able to pass distally, and we confirmed it with the OCT. And you can see that there are lesser struts after doing pot in front of the L6 ostium. And secondly, we had clearly gone through the distal strut. It is very clear from the diagram as well as from the moving image. And after the distal wiring is very, very important in provisional strategy, because that ensures proper scaffolding of some struts towards the side branch, and it is very important. And after that, we did a KBD, a casing balloon inflation, with a 3.5x10 NC balloon across LED and a 3x10 balloon across LCX. We initially dilated LED aggressively, and after that, when kissing was done, it was done at low 8 atmospheres only, so that we do not injure the L6 ostium. And after that, the report was done with a 4.5x8 NC balloon, and this was the final angio view, which we confirmed with OCT. And now you can see that there were no struts in front of the L6 ostium. Whatever struts were there, they had been cleared now. And this is the comparison that this is just after the LMC to LED stent. You can see there were a lot of struts at the POC, and after pot, they were decreased. And after doing kissing balloon inflation, there were no residual struts at the bifurcation point. And we also checked, it is also very important to see that whether we have caused any dissection by doing kissing balloon inflation. There was no dissection, so we had an optimal result. So the take-home messages from all these cases were that provisional is the default strategy in LMCA PCI. In case of complex lesions, we should choose upfront two-stent strategy. In provisional LMCA to LED, we should choose stent size according to the LED diameter, and proximal optimization should be done with appropriate size balloon. Distal rewiring is essential for scaffolding struts towards the L6 ostium. Routine kissing balloon inflation trials have not shown any better clinical outcome, and KBI should be done selectively, especially if L6 is dominant or distal disease is there, and ideally if OCT is present, that can really guide us. And OCT or any other imaging guided wire re-entry and removal of struts across ostium is associated with better clinical outcomes. Thank you so much.
So that was a lot of very nice cases bundled up. I would call it a bouquet of cases, I think, and I think it more or less sums up what everybody's been talking about today. And I think a brilliant set of cases. So we can sort of initiate a discussion.
I think he nicely summarized whatever we are discussing throughout the meeting. I think OCT is the way to go. I think if you do an imaging in the left main, I think you're very clear about the studs across the circumference ostium, and definitely if there is less than one or no studs across, you can just leave it. If it's more than that, there's a crowding, you need to go and cross distally and then do a kissing balloon. Very clear message.
Dr. Uday, we haven't heard from you for a while. Are you there? Anybody else would like to make a comment? Dr. Parikh? Dr. Shuvanan?
I think even if you are not using OCT or any imaging, you still can do the kissing so that you remove whatever, if at all, there are any struts in front of sir. So it is not necessary to have imaging and then do it.
So that again reignites the debate. So suppose you don't have OCT, would you do it as a routine, Dr. Showkathali?
I think so. So we all agree that not 100% of left main is done with imaging. So even if you look at the EBC main, which is a well-designed trial, one published in 2021, started in 2015, they've done only 40% of their cases were done with imaging, any form of imaging, either IVS or OCT, 36% IVS and 4% OCT. So even in Europe, even though I think that is one of the problem of the trial, because even if you look at the British Cardiac Intervention Society data from 2014, all the patients who had 2014 left main PCI, 50% had imaging. But here we are in 2020 when a trial has been done with only 40% imaging in left main. That is one of the biggest criticism of that EBC trial. But coming back to our general day-to-day practice, of course, we see sometimes acute patients coming. Some centers may not have imaging on site. So in those kind of situations, we cannot mandate that we will only do a left main with imaging, even though we will ideally want to do that, but in practical purposes, not. So when you do like that, it's better go for, when you're going for single strength, better go for recross. I think the most important point is if you are planning for kissing, always recross distally. So you pull the LAD wire and put it in the circumflex because you're a little more clearer that you're crossing distally, and then balloon it. As you rightly said, it's not a high pressure ballooning the circumflex. Well, the aim is to just move the struts out of the carina. So to avoid restenosis, it's not that we have to go high pressure and all those things. I have done in the past that I went high pressure without knowing it, and particularly long kissing balloons, and I dissected the left circumflex ostium. I had to put another stent, the tap technique. So I think we are learning a lot. Now we are saying that shorter balloons, 6 millimeters are available. Even 6 millimeters are reasonably frequently available in cath labs. We go for shorter balloons and just open up. So I think imaging ideally, but not everybody has imaging on board.
So I have a small question here, comment rather. For a very small balloon to put in the circumflex ostium or something, it will have a melon seating. Sometimes it makes slip out.
No, what I said is not small balloons. What I mentioned is same 1:1, but not high pressure.
Yeah, I know that. Basically, you need to have a balloon. There are two very important points about that. You should not have a long overlap of the balloons in the left main. This is number one. So it should be a moderate size length balloon.
8 or 10, whatever.
12 would have been a better size, always.
One thing which comes to my mind is that you have all these trials which were designed for left main interventions, PCI versus CABG, and again CABG still for some reason is a class 1 indication. With these imaging modalities, with you have functional assessment of these lesions, you have IVUS for the the ostial lesions, you have OCT for mid and distal lesions. You think in future you're going to have a change in the guidelines, or do we expect them to change the guidelines so to favor the interventionists?
I think if you look at it, see, as interventionists, we always want to be on the thinking little ahead. So when Excel was designed, people are thinking that now we are going to use a new generation regulating stents. We'll have a better outcome than CABG. So as the syntax, when the syntax was designed of multi-vessel PCI in CABG versus PCI, we all thought the old trials were done with taxes and all those things. Now but unfortunately, it didn't show any difference. But if you look at it, as the previous speaker has clearly mentioned, in Excel, the imaging was usually only in 25%. Sorry, even in Excel and Noble, the imaging was used only in 25% or less numbers when compared to that. I think what we really know from the Korean data, if you go back and look at their Korean data, they're all using 90% imaging. So if you look at the first left main, the Lemons trial, and the which showed very significant import, but that is around 90% imaging. I think the most important point is, even though we are telling that imaging will make a difference, but we haven't got the data yet. So we love to wish to see that data saying that imaging makes a difference.
And also, basically, if you look at the mortality of the most of the trials, if it is within the permissible limit of syntax, the mortality is not different. It is a re-intervention which is becoming different and which cannot be changed with anything.
Correct. I think that's the one thing we have to discuss with the family. I think if you are open about this to discuss with the family, there are so many people who would love to have it and come back in 2 years and have one more procedure again. That if they know that, so if I have a left main PCI, syntax 10-year hard endpoint say that there is no difference in mortality whether CABG or PCI, even though in multi-vessel PCI, there is definitely mortality difference is also there with the CABG compared to PCI. Whereas in left main group in syntax, 10-year mortality is the same. But in others, the CABG is slightly better than PCI, even in 10-year mortality as well.
Dr. Balbir, are you still there? No, I don't think he's there. So any more comments? Any final comments from the chairpersons? So in that case, I think we'll move on to the next case, and that's Dr. Rituparna Baruah from Guwahati. He is working with the Apollo Hospital and he's an accomplished intervention cardiologist there. So can we have your presentation, sir?
Good evening, sir. Am I audible?
Yes, you're audible.
Thank you, organizing committee, for giving me this opportunity to present this case. This is IVUS guided late main intervention. How does it change my practice? This is a 70-year-old gentleman, with a long-standing diabetic. He was non-hypertensive and with a good ejection fraction. Serum creatinine was normal, and he presented with CCS of class 2 and refractory to medical therapy. Angiogram showing double vessel disease and late main disease, and it was a very grossly calcified LAD lesions and a long diffuse disease. And osteoproximal LAD has 80% stenosis, mid LAD 80% stenosis, and this grossly calcified. And proximal LCX has 60% stenosis. So we found this LCX to be an intermediate type of caliber vessel, and there is a long tubular calcified disease in late main of 50% stenosis. So this angiogram was done elsewhere in other hospital, and then the patient presented with chronic stable angina, and then we did the guide shoot, and it's showing that there is tract calcification in the LAD, and there was very critical stenosis, and at the time of doing the angiogram, patient was having angina, and we showed that there was severe disease in the late main and the osteal LAD, and this is the right coronary shoot. It was non-significant disease, and we did the IVUS at the time, and before IVUS we just dilate the proximal LAD with a 1.5 millimeter balloon just to negotiate the IVUS catheter. And so this is the IVUS images, and they're showing severe calcifications, and there was circumferential calcification of more than 240 degrees, and it is superficial calcification noted. And the most critical lesion was seen in the osteal LAD, and we did the rota ablation, and then it was 1.5 bar was used with almost 180,000 RPM, and we did almost 4 to 5 times rota rounds across the left main to the LAD, and you can see that severe calcifications in the LAD, mostly in the mid to distal segment of the LAD, and then after rota. So there were some calcium cracks noted in the after the rota ablation, and luminal we have received some luminal gain, and you can clearly see the calcium cracks. And then we after that we dilated with a 2.5 NC balloon with a high pressure 20 to 24 atmospheric pressure across the LAD and to the left main. And then after NC balloon, and there was again luminal gain was noted in the artery. And then this is the actually wanted to show this the ostium of the L6, and it was shown no significant disease in the L6 ostium. And then we placed a, then after the IVUS run, and the subject to the based on the media to media. So actually the size was, the diameter was 3.25. So we selected for the distal LED, mid to distal LED, 3 by 32 millimeter graduating stent, and then we deployed it nominal pressure. And then we post dilated the distal stent with a 3 millimeter NC balloon with 20 to 24 atmospheric pressure, and then we deploy the second stent 3.5 38 millimeter graduating stent with an overlap of 3 millimeter, and from the ostium of the left main to the to overlap the distal stent. The stent was nicely deployed and responded well. And then we did the NC balloon with a 4 by 15 millimeter from the mid segment of the LED stand to the left main ostium with a 22. Distally we applied 15 to 16 atmospheric pressure, and the proximal in the left main segments to the and also the ostium of the LED we applied 20 to 24 atmospheric pressure with an NC balloon of 4 by 15 millimeter. And then you can see that the size of the L6, it was a non-dominant L6 with intermediate size vessels. And then we were actually, the plan of the treatment was to do provisional stenting and from left main to LED, because the lesion length was quite diffuse and long. So we opted for 2 overlapping stents right from the left main ostium to the distal segment of the LED. And this is the final shoot, and that both the stents were expanded very well, except there was some under expansion in the distal LED, and because it was eccentric calcium, that I'm scared of doing very high pressure balloon. Thought of that the normal segment can overexpand and might cause some complications. So I accepted some amount of under expansion because of the eccentric calcium. So this is the arteriocaudal view, and this is the final shot with a timid-free flow. So to conclude this my case, that is imaging, particularly IVUS, is mandatory for planning of left main intervention, and it can help while choosing or changing the strategy of left main intervention. Imaging clearly helps to defer or to avoid unnecessary side branch intervention or stenting. IVUS is helpful for left main ostial interventions. In this case, while doing the IVUS run, because of some error, it's not running. So, and there was no geographical miss, and the ostium of the left main was well covered by the proximal stent. It helps to recognize any geographical miss during the interventions. Thank you for your attention.
Thank you, Dr. Rituparna. I think it was a very nicely done case. No, it goes to show that you've done it's a large vessel, and you've rotablated with a 1.5 burr. So initially one used to say that okay, you need a burr artery ratio of 0.6 or 0.68 or something. So what we need to realize is that we do not use we should not have the requirement to upburr every time. And if you're it just even a 1.5 burr alters the vessel compliance to the extent that you could deploy your hardware well. The only problem with rotablation is that you have this eccentric bar of calcium which doesn't really work too well, but I don't think it really makes too much of a difference.
The only segment that was underexpanded is that eccentric calcium, so I don't have that orbital extractomy.
So if you want to actually deploy at a high balloon, pressure balloon, and an OPA and NC balloon works very well. So because it doesn't give you a dog boning, and it doesn't give you excessive expansion. But then you always have a risk when you have an eccentric bar of calcium to rupture the vessel at the at the shoulder. So that's what sometimes happens. So can we have the case open for discussion? Dr. Chandmani? Dr. Prakash, are you there? Yeah, I can see you.
You have to unmute, I think.
Yeah, nicely presented, Dr. Rituparna. Nicely presented case. Basically, whenever we are having a left main disease, I think if you have a imaging technique in your cath lab, I think in almost in every case of left main, we should use an imaging technique. If you have, particularly in our case, basically we have got IVUS, we have got OCT. So in almost in 100% of cases of left main, we are using either IVUS or OCT. So this helps us a lot. Basically, how whether we should go for the provisional standing or we should go for the double stent technique, or which technique we should go. This is very, very important. If you have an imaging technique, always use this technique in your cases.
Dr. Kartik, would you like to upburr routinely in such a, when you have a large vessel like this? Or
the problem with this case is the eccentric calcium. What happens, the wire bias is towards the calcium, rotablation works. If it's away from the calcium, rotablation doesn't work. Whatever burr upsizing you do, it doesn't work.
No, I'm not talking about the eccentric bar of calcium. I'm talking about the large vessel proximally. For example, you have a left main to a LED. This is a 4-2.
Usually, if it's a left main proximal LED, I choose upfront 1.75.
Yes, that's what the point I was trying to make.
We don't have the luxury of using 2 bars. The cost goes up. I straight away use 1.75, and then for left mains I do with 1.75.
The only problem with using a 1.75 to start with, if you have a lot of calcium burden, is a question of slow flow sometimes. So what I normally do is I keep one odd OO rota burr up my sleeve. So if the vessel is very complex, then I use a new one to start with, and if it's not very complex, I can. So it depends on what's available in your cath lab.
Yeah. What we have observed is over a period of time, I have stopped using ox bus. I use only N. The complication rate comes down dramatically. All the problem comes from the ox burrs. So you use one burr, do good work on that. And also the slow flow, of course, is an issue, but we use dobutamine and noradrenaline upfront and keep the pressures high. Usually we don't have the problem.
Once the pressures, my experience, what I find is if you have a long segment of occlusion and you have a lot of plaque burden, then it's better to start with a smaller burr and then up burr. And using O burr itself is not a problem. Your problem is using O wires or the advancer. If you ETO it never works most of the times. So this is what my experience is, and we
Can I make a point here about the rota? We do quite a number of rota because we are the highest number of rota in Eastern India. So I have a mutas operandi about that. We calculate the distal vessel and we take the bar as 0.5 to, and not 0.6, usually 0.5. So if the distal vessel is around 3 millimeter, I take a 1.5. If the distal vessel is more than 3.5, I take it to 1.75 bar. As simple as that. So, and the next point is guide wire bias can be changed. If you put the, it is very simple. If you put the wire in one branch, the guide wire bias will be one side. If you put the rota wire to another branch, the guide wire bias can be changed. Even by changing the guide catheter, you can change the wire bias. So if you see if you have an imaging and if you see that yes, your most of the calcium is one side, you can calculate which guide catheter you will be using and in which branch you should place your rota wire. There is a wonderful picture of guide wire bias and how to place it in Riesman's book. If you have a chance to see that, it is a very old book and it is one of the pioneer book on rota, and it shows that if you can change the rota wire in one branch, the guide wire bias can be changed.
Yeah, these are the tips and tricks you use while you do the rota, and if you find it is not it's eccentric, then you change the direction of the catheter, direction of the wire, put it in the side branch. Told, but it may work. Most of the time it works, but sometimes it may not work.
It will not work.
So, but does leaving a little bump in the corner, does it really, as long as you dilate it with an adequate size balloon, does it really make a difference?
No, it won't. I think, see, it will be it will expand in the other direction. That's all. So that little bit bump of calcium, you can leave it as long as.
So that's, in my experience, leaving a little bump of calcium really doesn't make a difference.
Doesn't make a difference. I think if your MLA is good, I think if you're using imaging, MLA is good, you can leave it.
Yes.
Yeah, that's it.
So any more comments? And I think now we have a middle order batsman who actually relegated himself to the tail end, and that's Dr. Batra, right? So Dr. Ankur Batra, are you there? Richard, do we have? We had one.
He has not joined. He got stuck somewhere, so I think we can.
That's the end of the session.
Yeah.
So I think it was a brilliant session, and I thank all the chairpersons, the panelists, the presenters, and the audience for bearing with us at this time of the night, where some people would be pining for a drink. Maybe we can bill Translumina, with our bar bills or with our dinner bills later. And I thank everybody. I think it was a brilliant thing. A lot of good take-home messages regarding left main interventions and what to do, what to use, the importance of imaging, and the fact that should you leave your side, address the side branch to leave some struts there or not to leave some struts there. I think it was an excellent discussion, and I thank everybody, and I thank Translumina for arranging this meeting. Over to you, Richa.
I think, sir, what you said is absolutely right. I think it was a wonderful session, and we had a great panel discussion. So, I mean, just like a name suggested, the name of the session, a lot of innovative techniques we have discussed for treating left main, that, what should be the right strategy, what should be the right hardware. So everything has been discussed here. It was such an interactive discussion, and, such interactive discussions always add a lot of value to scientific sessions. So thanks to all the chairperson for sharing your valuable experiences. Thanks to all the eminent panelists, speakers for bringing such scientific discussions on the forum and showing a lot of educational cases and sharing your views. Thank you, Dr. Nikhil, for exceptional moderation. And last but not the least, I would like to thank all the viewers, as we had more than 1100 viewers for the session. Thank you once again on behalf of entire Translumina team for adding value to the session and coming to BIC. Good night.